have shared all those cases with you all, sir.
Actually, I couldn't get time to see that. That's the problem.
No, you can. So I'll go in a cyclic manner. So in case if any other moderator or expert panel wants to raise a point, they can just raise their hands and
So that
everybody's thoughts would be taken.
Hi Joshi and
hi
ma'am, Lalit sir. Hi everyone.
I think Mr. Sunil should
be live, ma'am.
Yeah.
We are live.
A very good evening to one and all of you for yet again a very wonderful webinar on Retina, and it's really named Retina Avatar because that is how the whole sequence of the program in the next 3 hours is going to work out to. And we are truly lucky to have a absolute top-notch expert set of panel and great set of speakers. We are truly lucky to join with us soon Dr. Pramod Binde, who is the Senior Consultant and Director of Retina Department, Shankar Nethralaya, Chennai. Joining us soon is going to be Dr. Rajiv Raman, who's a Senior Consultant, Vitreous Retina Services at Shankar Nethralaya, Chennai, with us. And truly happy and a moment of great pride to have with us Dr. Mahesh Ji, Senior Consultant and HOD, Vitreous Retina Giridhar Eye Institute. And you have no idea the joy and the pleasure which I have. I should have taken his name first to have with us the President of AIOS, Dr. Lalit Verma, and he's just, there's no words to how to introduce him. He has given 20-25 years of his life to AIOS and nurtured it and made it grow in such a beautiful manner. And today having him view us on this webinar is a pure delight for me because I have wanted him there in every webinar of ours, but with his busy schedule, it somehow didn't happen. Joining us soon is Dr. Raju Sampangi, who's a Senior Consultant in Vitreous Retina in Uvia from Nethya Spandana Eye Hospital, Bangalore. And with us is again Dr. George Joseph Manayar. Truly is a pride of Coimbatore with his skill sets and as a Senior Medical Consultant, Retina and Vitreous Services from the Arvind Eye Care Systems based at Coimbatore. Moderating with me is Dr. Srinivas Joshi, who's the member ARC South. And I'm sure all of us are aware that is truly a dynamic, prolific surgeon, one of the directors of the MM Joshi Group of Hospitals, and probably the future of ophthalmology, especially in retina. And with him moderating, I'm sure this is going to be a lot more enlivening than I even could imagine. Our first speaker of this session is Dr. Lalit Verma, and I look forward to his very important talk on vitreoretina interface disorders. On to you, Doctor.
Thank you, Chitra. In fact, it's my proud privilege to be part of this wonderful group and must tell all of you that the wonderful work which has been done by ARC, not this year, but for the last couple of years, I am watching the programs of Chitra. Mind you, even if I'm not there, but I do see them live. On YouTube. A lot of times I view those programs, Chitra, and must say that during COVID times, ARC was the only wing which was functioning very, very efficiently. And thanks to Chitra and all the members of ARC, you see all the programs of Retina. I think Srinivas Joshi leads the way for all of us. And he's one man whom I am so proud of because I take it as a responsibility that, I brought him back from abroad to this country. That was around 9-10 years back. And I have seen him, operating a couple of times. And wonderful. So Chitra was saying, not only future, I think present also belongs to Srinivas Joshi.
Thank you.
And also very well, nice to see Divakant, Neha, and Mahesh, George. I always enjoy talks of George because he's so forceful and so impressive. And, very, very nice, panel of speakers and judges. Must say, we have done a lot of hard work led by Chitra Ramamurthy. So if you allow, I'll share my screen.
Yes.
Yes, sir, please.
Thank you.
Thank you, sir. Thank you very much.
So let me know if it is visible so that we can proceed.
Yes, sir.
I hope you are okay.
Yes, sir. Yes.
Thanks once again, Dr. Srinivas and Chitra, and all the best to both of you. In fact, I was fascinated by this avatar, the word chosen by Srinivas and Chitra Ramamurthy, and I hope I can live up to the expectation. You see, one of my favorite topic is interface pathologies, And before I do that, I'm very fond of, showing a normal OCT. The reason being, I still have this in my mind that everybody should recite once he's seeing an OCT, not like that edema plus and, macular hole plus. They should be able to, everybody, Chitra, should be able to recite all these layers. And out of them, these 3 layers are very important, that is the external limiting membrane, the AIOS junction, the RPE. But these 3 complex are the areas where the whole process of vision starts. And once we talk of OCT, we can divide an OCT retina into 3 parts. One is inner retina, the other is outer retina. Inner retina means between ILM, this is this layer where I am pointing my pointer, and the ELM is this layer. So this all is inner retina. And this is here the diseases are characterized by diabetic retinopathy or vascular blocks. Outer retina pathologies are between the ELM and the RPE, which includes things like AMD and other pathologies of macular degeneration. But what I'm going to talk today is about the junction. Junction is that where the vitreous meets the retina, and this is the junction. The black part is the vitreous, and this is the layer of ILM. So we are going to talk about junctional pathologies. I'm not going to cover anything about inner retina, neither of the outer retina. So we all remember that we are all born with 100% gel vitreous, which is optically clear. And normally this cortical vitreous are adherent to ILM with firm adhesions at disc margin, vitreous base, and variable adhesions in different people. What happens with age and disease, or sometimes trauma, or disease like diabetes? 2 things occur. One is this vitreous, which is normally gel, gets liquefied, and the other is the adhesion between the vitreous and the ILM that gets loosened or weakened. So if this liquefaction process and the adhesion process goes on concurrently and completely, then total PVD can occur. That means vitreous, liquefied vitreous can get detached from the ILM. So this is known as total PVD. And during this process of occurrence of total PVD, sometimes the tissue of retina or sometimes the blood vessel may come in between, and you may have a minor bleed, and flashes and floaters may occur, and there could be formation of horseshoe tears also. However, if vitreous gets liquefied, but the adhesion are still plus, that means a liquid vitreous then has potential to enter into the retrohyaloid space through a small peripapillary hole or a microleak. This initiates the process of PVD. It does not cause a complete PVD, and this movement of vitreous through the hole in the hyaloid, this initiates PVD, and this is a stimulus for cells to proliferate. And this process can be accelerated by trauma or disease like diabetes. This is further compounded by breakdown of BRB, and then you can have some membrane formation along its surface. So this is known as anomalous PVD or complete PVD, in contrast to total PVD. And this anomalous PVD can explain a whole lot of this junctional pathology, what we call VMT, lamellar hole, ERM, and macular pathologies. So this is one of the latest classification, which I think all of us should know, of VMA. This is an international classification, VMA and VMT. And the point to be noted here is remember focal and broad, and remember the 1500 microns. If it is broad, if it is more than 1500, less, it is focal. And full thickness macular hole, just see the definition, small, medium, large. Things to remember are 250 and 400. Less than 250 is small macular hole, and more than 400 large macular hole. So we'll just talk about a couple of these pathologies, junction pathologies, covering VMA, VMT, macular hole, and ERM. But these are today the bread and butter of vitreoretinal surgeons. You see, VMA by definition is that vitreous gets separated like this, what is shown on the OCT down, but remains adherent in a broad, dumbbell shape like this. But there's no pull on the retina. The retinal anatomy remains the same. So this is VMA, and VMA I think is a pretty common condition. In contrast to VMA, in VMT there is a pull element. If you see this figure's picture on the lower part, the retina is getting pulled up. So here there's an element of pull, and because the retina is getting pulled up, so you may have things like metamorphopsia, decreased vision, or macular edema also. So the key question which everybody faces is, does this VMT, which is being shown here, require intervention or not? So does the all OCT diagnosed VMT require intervention? No. The answer is a very big no, because the reason is a lot of these patients maintain very good vision, and have mild metamorphopsia sometimes, and therefore do not require treatment. What I call tolerable metamorphopsia, which occurs off and on. It all depends how much retina is getting pulled up, how much the distortion of photoreceptors is there. Sometimes what may happen is complete PVD may occur in this process of pull, and this results in regression of symptoms. So this is one patient, right eye, we had operated for macular hole. In fact, I saw this lady just now in the OPD. Left eye is still maintaining 6/6, but you see the OCT of left eye. There is a VMT, and OCT looks ghastly, as if the retina is under threat. But believe me, now it is more than 10 years for this lady still maintaining 6/6. In fact, right eye is now 6/9 today. So what I'm trying to say is, this lady who does not have any symptoms, absolutely asymptomatic. So we should not, enter into this, eye for vitreous surgery. This is an example of another patient. This patient had progressive VMT. You see, February 2016, I had advised no surgery. In June 2016, when it became tented up and patient started complaining of metamorphopsia very frequently, so we motivated this patient for surgery. And as we were doing so, he took some time, but by the time he came back again after 2-3 months, this VMT got released spontaneously. So this may also happen, that VMT released spontaneously. BCVA in this patient improved to 6/6 and 6, and patient symptoms also went away. So this can happen sometimes. So management of VMT is only and only when there is a disturbing metamorphopsia or decreased vision with the CME or macular hole formation. Believe me, in asymptomatic VMT, we do not and should not enter into the cavity at all. Believe, I always keep saying this, we do not treat this anatomy on the OCT. It is the patient's symptoms which are most important. And basic management is to remove this hyaloid face. And today with, advances in MIVS, this surgery is a relatively simple surgery. It does not take more than 10-15 minutes. And basic aim is to remove the hyaloid face. And all of us have been doing this vitreous surgery for very, very long time and very successful results. In between came, nearly a decade back, this injection by Jetria, and as if this will create revolution in the creation of PVD. But what happened was it came with a big bang and went away also with a big bang. The reason was that the results were not great. Results were around 25 to 27% only. With a single injection of Jetria, aim was to, the mechanism of action was that it could create between laminin and collagen, it could create a dehiscence, and therefore PVD could occur. But the expensive was $4,000 for one injection. And this was a landmark study, 2019, where ocriplasmin was directly compared with vitrectomy. And what was shown was, in patients who were treated with ocriplasmin, the resolution was 50%, whereas patients who underwent MIVS, the resolution was 100%. So therefore, the standard of care today in VMT, whether you are in the US, whether you are in India, is surgery and not ocriplasmin. And as I said, it is today the 25 gauge MIVS. What we do not resort to base dissection in such patient, but we do a near total vitrectomy. I do not indent this patient to take off the last bit of the hyaloid. Key step is the PVD induction. And you see, we all know that after we do a core vitrectomy, typically these two islands form in most of the patients. Is a tricot, stained vitreous, or tricot actually gets adsorbed onto the vitreous, and then gradually we engage with this cutter and gradually increase the suction. And sometimes it may take some time, but by and large, it's a reasonably easy job, and you get this separation plane very easily and eat off this hyaloid. And this is one of the patient where you see this was the VMT, and post surgery, this foveal contour has come back. Patient's symptoms have resolved. This was another patient. You see, this is gas-filled eye still being there. In fact, it was air, not gas even. We don't require long-acting gases in such patients. And you see how beautifully the foveal contour has come back. It's one of the most satisfying surgeries in vitreal interface disorders. The second pathology, which I would like to cover, is epiretinal membrane formation. But just for revision, in VMA and VMT, the culprit is hyaloid. In ERM, apart from hyaloid, it is the membrane. Because epi means membrane upon the retina. In macular hole, in addition to PHF and the epiretinal membrane, there is ILM, which is causing the traction. In ERM, what we do is, after having taken off the hyaloid successfully with the help of tricot, I normally put this trypan blue dye, and as is being shown here. I hope these videos are moving.
Yes, moving.
Yes. Okay. So then we try to identify this plane. And the key step is to separate this bad element from the normal retina, that is the epidermal membrane, which is a pathological membrane. Once this plane is identified, then it becomes a very tricky job, and you can take hold of forceps and peel it off. Here I am continuing with the help of this bent MVR blade itself. And this generally membrane ERM comes in single sheet. It's very, very rare that ERM will come in multiple sheets, unless in diabetic patients it may happen, but in idiopathic ERM, generally epidermal membrane will come out in a single sheet, as is shown here. This is another patient who had dry ARMD, as you see these colloid bodies, and had an epidermal membrane and was very much disturbed. He was an advocate, and we began this surgery by MIVS, do a core vitrectomy, put in some tricot crystal there, and after the hyaloid is gone, then I make it an air-filled eye. And this is the last bit of fluid which is being taken up, and under the air I will inject a couple of drops of trypan blue. This is different trypan blue. This is concentrated trypan blue, or more percentage than what cataract surgeon use. And after staining for a minute or so, under the air you take out the excess trypan blue, and this is the last bit of trypan blue which is coming up, and then you put on the fluid. And once this is on, then the favorite instrument for identifying the edge is, for me, it's a 25 gauge MVR blade, as is being shown here. And once the edge is created, then you take hold of Arcard forceps or end opening forceps. And as I said, this membrane generally will come out in a single sheet. And once we are peeling this membrane, always keep an eye on the underlying retina. But that is very important, because you should not have any iatrogenic issues once you are peeling these sticky membranes. So this is the result of the same patient. A lot of times we combine cataract surgery along with this removal of such membranes. And although contour may take some time to come, but it takes a couple of months before this contour comes back. ILM peel in a pure ERM, we always do try to peel off ILM, but not at the cost of repeated massaging that area. If it comes out, very good. If it does not, it is not a must to remove ILM in a pure ERM. So in fact, global trends also show that ILM peel in ERM surgery is not advantageous. The only thing which peeling of ILM ensures is that all the membranes in front are taken care of, and maybe future formation of ERM is less. The last thing in interface disorders is macular hole. And as I said, in macular hole, the third membrane which has to be removed after you have taken care of the hyaloid, or if there are any associated ERM, is to remove this ILM. And the best dye to stain ILM is BBG, also known as blue ICG. And a lot of people prefer this diamond dusted. And today, frankly, I have given up usage of diamond dusted. And what is being shown here is the ILM peel, where you pick the, take hold of the ILM, direct pinch and peel, and take it across the macular hole. This is what is known as ILM peel. And normally in the first surgery itself, we, create this ILM peel from arcade to arcade, and notice that it is being taken across. This is a typical ILM peel, which is being shown here. As you see, we have taken out the entire ILM. And this is the result of this patient, what you see, macular hole. And this is the post-op OCT, as well as although gas is still inside. There's another patient, left eye macular hole surgery done, and the contour restored. There are some controversial points at how much duration of tamponade you should put, but believe me, OCT had made us wiser. Most of these holes close within 1 or 2 days if the surgery has gone uneventful, and post-op positioning is not required for weeks or months. In fact, nobody today should scare these patients, even though patient may be obese or neck problems or cervical spondylosis. In fact, if you put them head down or a reading position, these holes generally close. So this was another patient where all the 3 membranes were taken, removed. This was first was the hyaloid, and you see this tricot assisted posterior hyaloid removal being done. And then I will, put in air, do an airflow exchange, and then put a few drops of trypan blue to stain this epidermal membrane, which was a big membrane in this patient. and then take this favorite instrument, that is the MVR blade, identify the edge, and peel off this epiretinal membrane. And it's a big membrane. And even if you see there's a lamellar macular hole also here. And once this epiretinal membrane was peeled in this patient, then what I saw was the rest of the retina was still wrinkled. So we proceeded on to, the third membrane, that is the ILM, and we injected for this the BBG dye, which is being shown here. This BBG dye is after a few minutes, then we go direct pinch and peel technique. And this is the last third membrane, that is the ILM, which is wonderfully stained here with this BBG dye. And we again peeled off this membrane here, what is being shown here. And this is was combined with cataract surgery also. And this is the post-op result of this patient. Pre-op is the upper one and the post-op is the lower one. And this is the OCT of the same patient where this 4-in-1 surgery, that is cataract, hyaloid, epiretinal membrane, as well as the ILM was removed. Fortunate that patient could recover good vision. This is one of my last video to be shown here. This was one patient who was following up with me for more than 12 years, and she never agreed for surgery because vision was, she was much scared actually. Some people had scared. And at that time, I had just attended a workshop wherein ILM flaps were being discussed. And this was my first ILM flap surgery. I thought I'll share with you. Here, this same lady, direct pinch and peel technique. The difference here is that instead of taking this ILM across, we just leave it at the edge and then create multiple cauliflower-like ILM flaps and put them at the edge of the macular hole. And then rest of the ILM around that is also removed. So this is the scene after you have created multiple, flaps like this. And after that, once you have created multiple petal-like ILM flaps near the macular hole, I will take off and then remove and then reduce the size of this by lowest possible section, that is 50, and the highest possible cut rate. And this is the result of this patient. You see more than 1400 macular hole size. And typically what we have seen is that after you do a flap surgery, the closure is generally type 1 kind of closure in most of these patients. This is another patient who had large macular hole, very large macular hole, or extra large macular hole with type 1 closure with flap. This is one patient who had a macular hole surgery done, but macular hole still persisted. In such patients, there are a lot of things which has been described, but I, for one, do only ILM graft. I have not done any, I've done one retinal graft, but a lot of people do a lot of retinal grafting, as well as some people do lens capsule grafting also. This video just shows how to do ILM graft. The ILM is in the extramacular area, we are preparing a teasing this ILM from the retina just near the disc. And after this has been done, what we do is put PFCL bubble, because it's very difficult to manipulate this ILM and place it onto macular hole without PFCL. And fluidics has to be taken care of. And in such patients, you always have to have a valve cannulas. Otherwise, this ILM will move. So now this flap, which was, prepared, gently, very slowly, this is being maneuvered under the PFCL bubble. And this will now be positioned onto the macular hole. This is the bare macular hole, what we see. And this is the flap now, because if you don't have PFCL, this tends to move. And once this has been done, then you can, do air exchange and come out. So, thus to summarize about this VR interface disorders, it is the OCT and the newer theories of PVD, which I said anomalous PVD, which have helped us in better understanding of all these interface disorders. And today, all of us can vouch that all these interface disorders, whether it is VMT or epiretinal membrane or macular hole, or all three combined, with the help of current instrumentation and better understanding and techniques, they can be virtually treated very, very well. And a lot of these patients recover very good vision, not only, and also anatomically results are very, very good. Thank you very much, Dr. Chitra and Srinivas, for asking me to join your group. Thank you so much.
What an amazing teacher you are, Dr. Lalit. Hats off to you. I enjoyed every second of it.
Thank you, Lalit sir. Those were the very beautiful videos you had shown, even though of the large macular holes and the closing and everything. Thank you very much for that wonderful presentation you did in 15 minutes. Sir, my question was, any tips for the youngsters? Like you showed those kinking vitromacular traction, where trying to even, trying to induce a PVD could have caused de-roofing of those and caused a iatrogenic macular hole. So any tips for the youngsters how to prevent the occurrence of the de-roofing or occurrence of the iatrogenic macular hole is the first one. Second one, what's your experience now? The newer terminology is epiretinal proliferation. Now they have call it as lamellar hole epiretinal proliferation, macular hole associated with epiretinal proliferation. And many of the authors say that don't peel it, leave it, just trim it and leave it, because peeling more across would enlarge the size of the hole or it might damage the hole more. So these two questions I just wanted to ask you quickly, sir.
Thank you, Srinivas, for these pertinent questions. For shortage of time, I did not show another video. The answer to both these questions is by and large similar. What we do in such patients who have marked tenting and what you said was wrinkling, we do a foveal sparing PVD induction. I will not, once we engage, so we go round and round, but we leave a small stump of the, hyaloid attached there. So that we call foveal sparing PVD, and the, believe me, results of foveal sparing PVD and that once we constantly pull are similar. I have two videos. I will, for shortage of time, I will not, but we do a foveal sparing PVD and very gentle. You should not keep pulling, as I said, what a video I showed, that you keep pulling from 200, 300 suction. That should not be done. Because if you keep doing that, then iatrogenic macular hole can occur.
No, in case if it is associated with ERM also, where you might have to do an ILM peeling. So in those cases, sir, how would you?
So same thing. You see, as I said, our eye has to be on the underlying retina. And because once I will, we will go 360-degree, peel off the hyaloid or the ERM also. And then what will I do as a low suction cutter? Low suction cutter, I will trim it rather than peeling, whether it is ILM or whether it is ERM. I will leave the stump attached at the center at the fovea. And I will not pull any of these membranes because that has the propensity to cause a full thickness macular hole at that.
Is there any relevance of grading metamorphopsia, any clinical sense to it?
I don't know whether metamorphopsia grading has been done on Amsler. We do give patients this Amsler, but clinically, I ask them, how much are you disturbed? How much, in day-to-day life, you are bothered for metamorphopsia? Because if patient, even if he may have 6/12, 6/9 vision, so we may go in, because we may go inside and peel off the hyaloid. And if patient has what I call tolerable or occasional metamorphopsia, like kabhi hota, and then it is not bothering him, then we don't go inside. And when the video which I showed, that patient, he had, very disturbing. So this patient, even though he may have good vision, you should, go inside and take off the hyaloid, because believe me, it's one of the most satisfying surgery. Even though foveal contour may take months to come back, but symptoms go very, very fast.
Thank you, sir. Thank you very much for that wonderful talk. Yeah, quick comments from Pramod sir and Mahesh sir before we go on to the next talk.
Basically, what Dr. Lalit said, I agree. Rather than previously, we used to talk about some guy 618 or suppose less than that vision. But what is important now, how symptomatic patient is, more than that, worsening symptom. If patients documented history that he said, yes, progressively worsening, probably that is the indication now, even if 6/9 vision is there, I would put it that way. Okay?
Absolutely.
So, and coming with the previous thing about fovea sparing, probably it's better what we do is start inducing PVD on a nasal side of the disc. And once you start on nasal side and then come back last on a temporal side, because sometimes if you're trying to induce at a temporal side, then you do not have control. First thing will, before you realize comes up, it is de-roofing of the macula and posterior hyaloid comes up. So start consciously on a nasal side and then go all around and then slowly trimming and then approach fovea, the last one.
Good. Thank you, sir. Thank you for that tip. Yes, Mahesh sir, last point.
Yeah, actually, Lalit sir, one point, you are peeling arcade to arcade ILM, right? A few years back, Yeah, we have had a publication in Retina. My other surgeon peeled a small 1 disc diameter only. I peeled large area. There was no, it was a RCT sort of thing, not completely, but we found that there was no difference in the area of peel.
Success rate. Yeah.
So, but generally, we don't want to leave ILM very close to the that is what.
You see, we are, what I may say, if you permit, we are all ILM addicts.
Yeah.
Once we start peeling, we want to peel more and more. But you are right, there has been described what is known as mini peeling or so. People have described that. And within the center for sight also, there are people who will have only, say, 1 disc diameter around, success rate of that, and this is similar.
Similar.
Thank you, sir. Thank you very much for that great discussion.
Thank you so much.
Sir, for that wonderful talk. I request you to please stay on for.
Stay on with us, Dr. Lalit.
Yeah.
I will have to go in between, but I'll come back.
Yeah, you can come back, sir, after going.
Back.
Okay,
So,
next, Chitra madam.
Next speaker, Dr. Divakant Mishra, who's again very dynamic young retina surgeon from Swarnajyoti Eye Hospital, Lucknow, and he's going to show us a surgical case management of subretinal cystic surfaces.
Yeah, and each case will be of 5 minutes and 5 minutes for the discussion by the expert panel. Welcome, Diva, and please go ahead.
Thank you so much, sir. And thank you, ma'am, for this invitation. I'll start sharing my video.
Is this a voiceover or you are going to talk on this?
So the voiceover is there, sir.
Certain
Okay.
relevant investigations. You need to share the sound. The sound is not coming.
You should start from the beginning. The sound is not coming. I think it's
Diva, I think it is better that you
Should
tell
I-
us.
So I'll mute the video and do it.
Yeah,
manually.
please,
Yeah.
please.
Yeah, so good evening and thank you again for this invitation. I'll start the video again.
A 25-year-old male patient presented to us.
So this is a case of a 25-year-old male patient who had presented to us with acute diminution of vision for the past 2 weeks. On examination, we saw that the vision was counting finger 1 meter in the left eye. Anterior segment examination was absolutely normal. There was no signs of any inflammation there. On examining the posterior segment, we could see a small large subretinal lesion, which was involving the whole of almost macula. We ordered certain investigations like OCT, ultrasound. We referred the patient to the neurologist as well. This is the image of the OCT, where we can see a well demarcated hyporeflective large cystic lesion, and along with that hyperreflective walls. And then we can see some hyperreflective lesion which could be possibly scolex attached to the wall of the cyst. And now then we clinically diagnosed the patient as subretinal cysticercosis and put the patient on oral corticosteroids and planned vitrectomy for that patient. Now we have put the patient for 25 gauge 3 ports pars plana vitrectomy. Initially, the core vitrectomy was done, and if the video is visible, you can see the classical undulating movements of the cyst right there. Initially, we tried PVD without triamcinolone, which was frankly not very successful. Then we used triamcinolone assisted PVD induction was done. And then we went ahead with complete vitrectomy. Now, while the PVD was being done, superiorly, we can notice a sort of a macular hole had also developed after that. Then a small retinotomy at the edge of the cyst was made. And with the help of active suction, we tried to remove the cyst in toto. Now here carefully the cyst is being removed, and now the macular hole is also more visible there. This is the cyst, and the undulating movements can again be observed. After that, we use the cutter with high suction and high cut rate, and we literally ate up the cyst as quickly as possible. After that, fluid air exchange was performed. We did not laser the retinotomy, as we assume that the retinotomy will close with fibrosis, and we did not do any extra maneuvers in an attempt to close the macular hole. Then SF6 gas was injected, and the patient was advised prone position for a week. Now this is the post-operative image. I don't have a very good OCT because the patient was referred from some other center. The patient did pretty well with around 618 vision at around 3 weeks of follow-up, and the macular hole also appeared closed on that follow-up. Thank you so much.
Wonderful.
you.
Wonderful, Devakant.
Thank you.
Thank you, Diva, for that wonderful case.
Thank you.
Yeah, so I now request George sir or Dr. Rajiv sir to please go ahead with the discussion. I just had one quick question, sir. In case the beautifully Divakant showed how the cyst came in toto, but in case if the cyst does not come in toto, then what would be your management in such cases? And would ILM peeling would have definitely helped because there was a clearance of the occurrence of the macular hole. And if so, how gently we have to do a PVD in such cases to prevent the happening of the macular hole in such cases? And would ILM peeling in these cases would have helped in the early closure of the mac hole? Although he has shown the OCT is not available, but we believe in what Diva says that, and looking at the vision, it looks like the mac hole has been closed. So your views on that, sir, quickly.
It's always exciting to see this submacular cysticercosis being removed. As you said, removal through the retinotomy, he has done the correct technique only with the periphery of that cyst area, cautery, and it has to be very gently insinuated out, because if you don't remove completely, then it is a problem. I don't think there is a role of ILM peeling because it's not a tractional macular hole. It's not a, it's not a age related or tangential traction. It's basically not related to that. So ILM peeling is out of question. But what I would have done slightly differently is mild at the edge of that retinotomy, I would have given a few burns and nothing for the macular hole as such. And I would be interested whether this patient was started on albendazole or anti-helminthics for this patient. And also, if you are starting on anti-helminthic, it's very important to get a CT or MRI brain, because usually the ocular cysticercosis can have concurrent neurocysticercosis also. So if you're giving albendazole, we usually give 3 days prior or 2 days prior albendazole with a mild dose of steroids before we take up these patients. But we take the brain scan to see if there is any neurocystosis because cysticercosis, because if you start albendazole and it causes the cyst in the brain, the death of cysticercal cyst, it induces brain edema and patient can go in for even convulsions. So it's important to image the brain as well. These are my inputs on this case.
Thank you, sir. Very pertinent and relevant. Rajiv, sir.
I think a beautiful case and very well managed. And I fully agree that the question which you had, that if it was not coming fully and you have partly eaten up. See, previously, this was a very important thing that you have to bring the cyst exactly like that. But now we know that if it gets broken also, only thing which may happen is a more inflammation. And as Dr. George rightly said, that these are the cases you tend to give a pre-op steroid. And these are the cases where you know that there may be a little more inflammation as compared to one where you have removed totally. So I think nothing to be greatly worried about that, even if it has not come in toto, but you try to definitely make sure that if you can bring it like what he did. And I would also have lasered, because that hole seems to be a little bigger one from where it has come, though he could manage it and nothing happened. As far as macular hole, another thing which I felt when it came out, there is a lot of inflammation also inside. The cyst induces, though you could see some clearing, but again, he's the right person, whether there was a real hole there or it was just moving of that exudates and that creating a space looking like a hole or thinning alone is something, because it closed very properly. The fundus picture definitely showed that it closed. OCT would have definitely added value.
Thank you, Rajiv sir. Pramod sir, yes, last comment.
Yeah, so a couple of things I would have changed. Probably I would have done retinotomy in a horizontal raphe rather than somewhere macular area. That is one thing. Yes, approach is little bit we have to awkward, but if you plan your sclerotomy well, then the chances of having a scotoma and all those things minimized. Probably age of the cyst little bit away, because it is partly coming on the cyst. What happened with the light, with your cautery, you are like exciting that cyst. Movement become much more vigorous. And what Rajiv was telling now, what happened, and we have an experience in front of my eyes, because then cysts start moving, they try to push through, and the thinnest part of the retina there is fovea. And the first thing what happens is try to pop through fovea. Okay, so in front of your eyes, you'll end up. So once you are in, while doing vitrectomy, you have a very minimal illumination. But when you are right on the cyst, then you have to move quickly, because then your retinotomy, your light illumination, then you just have to get it out quickly before it just pierces through fovea. It's like a antenna-like thing come through the sharp cystic thing, and it just push to the fovea. We have experienced that one. Okay, now cyst is like it's very malleable, very wall is very tenacious, but very tough. It doesn't break that easily. So even if small tiny hole retinotomy, it delivers itself out easily without getting rupture, unless you are really rough handling. What he has done, it came out very well. It just squeezes out itself. You just have to give direction, little bit tug, and it just comes out on its own. Only thing, you have to keep on nudging it. So that could have been done. Now, most of this is, we don't know, like there is a controversy about how it comes in a subretinal space, but something generally through choroidal vasculature. And when it is in a macular area, vessels around that area generally have already RP atrophy underlying, and I would say 6-18 vision is got excellent outcome, considering cyst sitting there. Otherwise, this area invariably have a scar, and vision may not be that great. But I think very well done surgery. Yes, I would have done laser as well. What I agree, both George and Rajiv. If there is no neurocystic probably then you do not need to give anti-helminthics. That is one thing. And I think he has done already CT. So that is one part. In fact, if there is neurocystic before starting anti-helminthics, neurologists suggest that you get your cyst out under steroid cover, and then with steroid couple of days, and then they will start anti-helminthing, because there's more worry about cystic sarcosis, because all these scissors and all those issues later on, and they are worried. But what they suggest is get your intraocular cyst out, and then they will start anti-helminthing. That's the way generally it works too. Okay.
Thank you.
Very well done surgery. And still same thing you can do if you want to easily. This comes to your regular sclerotomy, 20 gauge sclerotomy or 23 gauge sclerotomy. Intact cyst will come out. Nice, you can send it for your histopathology. So without really much effort. But yes, previously we used to insist on removing because we were not sure about. Now we know you shave it off. Thorough lavage. There is no intraocular inflammation at all after that.
Thank you, sir.
Shall we?
Thank you, Diva. Wonderful case.
Wonderful case. So Dr. Rakesh will go next. So we have Dr. Rakesh Juneja, who's a consultant vitreoretina and neuro-ophthalmology from Juneja Super Speciality Eye Hospital, Bilaspur. And he is going to talk about functional analysis of CNVM using microperimetry. On to you, doctor.
Thank you, ma'am. Is my screen visible, ma'am?
Yes, yes.
So I'll be speaking on the functional analysis of the CNVM using the microperimetry. So this is basically a sort of a novel tool. We all know that the wet AMD comprises of the abnormal blood vessels that oozes the fluid into the subretinal space and that hampers the vision. A lot of these structural tools are available with us with providing the various biomarkers that are helpful in assessing the CNVM. The most important is the OCT, and then the age-old tested time modality is the fluorescein and the ICG angiography. Of lately, from the past few years, we have the OCT angiography that gives us the structure and the details of the neovascular network that helps us in analyzing what kind of the pattern of the network is lying beneath. However, with regards to the patient's perspective, we still lack the functional aspect, how to measure it while the CNVM is new, or once we go ahead to treat it with our regular anti-VEGF injections. So there was a big gap between the structural, that is the morphological aspect, and the functional aspect. So this is the tool we really look forward to, which is subjective, non-invasive, and provides us the retinal function. And it is a quantitative data that gives us with a point-to-point correlation with the structural aspect. So this is how the microperimetry picture looks like in the presence of a normal choroid, in the absence of a neovascular network, and in the presence of a neovascular network, where one can see there is a depression of the sensitivity at those particular points where the fluid or the network is located. So we try to correlate with this functional data available with us with the microperimetry with that of the structure, that is the OCT angio. So I'm putting across few cases. This is the first case where we had the presence of a neovascular network on the OCT angio. One can see that the in correspondence with the network, there was a depression in the sensitivity with reduced functional points at the region where the network was located. We injected the case with anti-VEGF. There was a shrinkage in the size of the network with some improvement in the functional sensitivity at those particular points. And with the more injections, the functional sensitivity went on increasing, and one could exactly pinpoint and even tell the patient with regards to the improvement in the functional outcome at what is happening at that very particular point where the network is located. So this is the second case where again one can see a reduced functional sensitivity at the areas of the network. With the further subsequent anti-VEGF injections, the sensitivity went on increasing as the network regresses in size structurally. And with the more injections, there is further improvement in the functional sensitivity on microperimetry with a further reduction in the size of the network. So putting across one more case, not only one can localize the area, one can also see at what very particular point the exact the sensitivity is depressed. So this is the one more case where with the regression of the network, there was an improvement in the sensitivity, and with the last injection after 3 months, there was a much improved functional response. I would like to highlight this case. This was the first case where we had the improvement with the reduction in the network size, but with the recurrence of the network following the anti-VEGF injections, once they were stopped, at the 6th month, with the resurgence of the network, there was again a reduction in the sensitivity, which was very well mapped with the help of the microperimetry. So we also reviewed the literature, and we found this study that was also doing some work on the microperimetry and the fundus autofluorescence in patients with the AMDs, and they were also able to correlate with that of the autofluorescence and the microperimetry. So this microperimetry not only helps us to give the functional aspect, one can also go on to correlate. So this is a sort of a tool that bridges the gap that was unbridged between the morphology, that is the structure, and the functional aspect. So this is what the software can also do. It can give the, if you club the OCT angio with the microperimetry, you can have the structure and the sensitivity correlation at all the points of the network, and you can beautifully elaborate your picture, and you can see at what points how the network is behaving. Is it really dead? It is a tree trunk appearance. It is still oozing the fluid or not.
Doctor, 1 minute left.
Help you to analyze. So it is a subjective test which requires patient's cooperation. It is a very novel tool where you can know the sensitivity and get the point-to-point correlation. And it provides new insight into the pathogenesis, prognosis, and progression, and improves the compliance and confidence. And yes, we can say that Now we have a certain tool that helps in the functional analysis of the CNVM and will help in correlate with its structural counterparts. Thank you.
Wonderful talk, Doctor.
Really nice presentation, Dr. Rakesh, because not many people have really worked on the microperimetry and its correlation with the octa. I think it was really a wonderful cases you showed. Thank you very much, Dr. Rakesh. Now I request Raju sir is here. Raju sir,
Yeah, yeah.
Dr. Mahesh. Yes, sir. Request you to please go ahead with the discussion.
Very nice study. But I just wanted to ask you that did you try to correlate with the OCT also? See, basically, we are trying to look at one pathology of neovascular growth that is there. But what about the corresponding OCT image also? Did we try to do that? And how does it add value? Suppose if I have to have a microperimetry, how would your study add value to me to make a decision to treat or not to treat? Does it give that kind of information?
Sir, that is a very interesting question. I would like to answer both the parts of it. First is that we did in all the cases OCT with regards to the time preference. I just showed the major chunk with the comparison with the OCT angio here. Although in all the cases, the color photo, the OCT autofluorescence, if possible FA, and the OCT angio and the microperimetry analysis was also done. We also did the overlay part as well, but since the time of 5 minutes does not allow me to show all in one single go, that is why I have removed the OCT part here. So there was now the answering your second question. There was a case with us who had a diabetic nephropathy, and somehow the FA was not possible. So what we did, and the patient was having 6/6 partial vision, and we could see the network lying there. And on the clinical appearance, it was looking like a dead network, which was not actually oozing. And the patient had a very good vision with very minimal scotoma. We were in a dilemma whether to go ahead with the injection or not. We did the OCT angio. Certainly, we could see the network there, but now we relied on the microperimetry part here. The sensitivity was superb. It was slightly depressed to 30. And the patient was even not that happy to go ahead with the anti-VEGF injections. So this presence of the microperimetry allowed us, or sort of gave us the license to not to treat at this particular time. And we went on to observe the patient on the basis of the OCT angio and the microperimetry to decide till actually the fluid was seen on the OCT, and then we went ahead with the treatment part. So this is, sir, one aspect which can help us to really guide to the treatment part.
Nice. Very
Thank
good.
you.
Thank you. Anybody
Yeah,
else? Two
thank
hands
you,
up.
Rakesh. Rajiv, sir,
Yes.
quickly, sir, just I'm yet to understand what are the clinical implications? How will it clinically going to really help us?
See, there are two things. One, we have published in IGO the microperimetry after in CNVMs after anti-VEGF. See, three things you can make it out from microperimetry. What happens to the absolute scotomas, what happens to the relative scotomas, and how the fixation characteristics change. So after anti-VEGF, if you see this trend happening, because some of the absolute scotomas become relative scotoma, some relative you get, so what he showed, the red ones are the absolute scotomas, the yellows are actually yellow and orange are the relative scotomas, and you can see that bunch of fixation characteristics, like whether it is predominantly central or it is paracentral or some eccentric fixation. You can make out after 1 or 2 injections how the characteristics are changing. That can give us some idea about the functional outcome of this patient. So we had a series of some 20 cases which we had shown in which we had published, that how in month 1, 3, and 6 there is change in these 3 parameters. So you need to look at 3 to suggest that what would be the functional improvement, because these scotomas are either because of the fibrotic component of the CNVM or the fluids. Ultimately, it is the fluids which will get changed. So I think it assists in some way to tell the patient about the final outcome. However, based on that, treatment is something which has not yet evolved.
The NFAS OCT correlation could help in these cases, I guess. Like you can try to correlate with the ANFAS.
The place where microperimetry people have tried as far as treatment is concerned is treating diabetic macular edema. People have tried looking at microaneurysms where the sensitivity was high. They didn't treat that because you are creating there a scotoma. So if you have a leaking microaneurysm and you see the retinal sensitivity high in that area, you tend to avoid these microaneurysms when you are treating. That's the only way clinically, as far as treatment is concerned, people have used microperimetry.
Thank you, sir. George, sir, your last comments, please.
Yeah, just a quick comment. I would agree with Dr. Raju that though MP3 with the newer superimposition with Octa and fundus imaging is an important part of the, the jigsaw piece in the multimodal imaging part of
Chaitra is in a marriage, it seems.
age-related macular degeneration.
If he wants to
But
go
still, it would have been better if you had put it as a combination of
We'll take it
OCT,
later.
Octa, and MP3, because that gives a more holistic picture, because Octa cannot be used alone for retreatments and considering the treatment decision. As Dr. Rajiv was saying, it will show improvement in sensitivity and then again, reduction in sensitivity. So if you combine all this, but I feel that in ARMD, other than CNVM, it's out of context your case, but in dry AMD, now we have this CAM classification, a OCT based classification. Not only geographic atrophy, the progression of the dry AMD, we really with fundus autofluorescence and OCT. But when you do this MP3, it could be easily showing the spreading or enlargement of these atrophic areas. That's a very, because newer treatments for dry AMD, this could be a very sensitive indicator and to predict how it progresses in combination with fundus autofluorescence, and it will help in newer treatments for dry AMD.
Only thing,
George, probably this will help to decide when to stop treatment if it is useless, no?
Yeah.
Other way we were using microperimeter, but that was MP1 because MP1 had a feature of biofeedback training, which MP3 doesn't have. So we used to use it for bilateral scars, giving a biofeedback training so that the extrafoveal location attains this and increases the sensitivity. And especially myopic CNVMs or choroiditis with a central scar. But now we cannot do it because MP3 doesn't have that.
Thank you very much, George sir and Rajiv sir, for those meaningful discussions. Thank you very much, Dr. Rakesh. Hope we could see much more studies on that, and when it becomes really useful clinically, please do let us know. We'll be really happy to know more about it. Yes, Chitra madam.
Yeah, we shall now go on to, there's a small, we'll go in sequence for a bit and then we'll change gears for one or two speakers. We have Dr. Vishal Agarwal coming next, who's a senior consultant from the Agarwal Hospital, Jaipur. And he has another very interesting situation of post-dex implant endophthalmitis. On to you, Dr. Vishal.
Thank you, madam. Thank you, Srinivas, and thank you, AIOS ARC, for having me here. Am I audible?
Yes, yes.
So I'll be just sharing a similar set of complications which I faced recently after the DEX implant injection in a different set of conditions. Just a brief, we all know that Ozurdex is an intravitreal sustained release biodegradable implant used for the treatment of macular edema for RVOs, diabetic retinopathies, uveitis, and many other off-label indications also. We know the dimension 6 mm in length and it's 0.46 mm in diameter. And common complications are, amply, described in literature like conjunctival or vitreous hemorrhage, cataract progression, and increased IOP, which can be managed medically very well. But endophthalmitis, infectious endophthalmitis after dexamethasone implant is rare. No cases of acute endophthalmitis were reported in the Geneva study. One case was reported in the MEET study. So I'll be just sharing my video of two different cases. Okay. The first case is of a 56-year-old female, and the patient was pseudophakic and had NPDA with diabetic macular edema, and Ozurdex was given for it. And after 3 days, she presented with this picture. And you can see there is a hypopion, anterior chamber exudative membrane. She was implanted a multifocal somewhere else with the flax. And we went inside and you can see the whole vitreous cavity full of exudates. And the interesting point here is, in both cases, in fact, is that all the exudates, seem to be radiating from that implant. It's all concentrated around that implant. Anyways, after doing a little core vitrectomy and clearing all the exudates, we the retinal visibility was there and the implant could be seen. And this was my first incidence of explanting or dealing with such cases. So first I tried to take it out with the handshake technique. Lift it up with the forceps, and with the other hand, I tried to, take it out, but it was a failed attempt and it again fell on the retina. And the second thing I tried was eating it up with the vitrectomy cutter, with reducing the cut rate and increasing the suction a little bit, but it kept on slipping actually. And I just could nibble a little part of it and it kept on slipping. As you can see, it's not getting eaten up by the cutter and it's slipping again and again. Finally, I enlarged my main port with a 20 gauge MVR, and as you can see, and just held it with the end gripping forceps and aligned it in its longitudinal axis, the long axis, and just took it out like any other linear foreign body. And after that, instilled intravitreal antibiotics and did a little AC wash, and the patient did fine. And this is the post-operative picture after 2 weeks. Coming to the second case, this patient was a 65-year-old male, and this patient was a phakic patient with 636 vision and a patient with the retinal vein occlusion and macular edema. And that was the indication for a intravitreal Ozurdex implant injection. And the patient came again after 4 days with pain, blurring of vision, and hypopion. And we cleared the AC again. The cataract was not that dense. And this time I was wise enough. I had experience around 3 or 4 weeks back. So I did not attempt many other maneuvers like eating it with a cutter or trying to take it out without enlarging the port. Again, did a core vitrectomy. So that to make the vitreous cavity a little clear and to see the details of the retina and the position of the implant. After that, the implant was held up in a similar way. First, the incision was enlarged with the 20 gauge MVR. The implant was held with the end gripping forceps, again aligned in its long axis, and just gently removed in one piece. You can see the alignment is very important, otherwise it will keep on slipping through the port.
1 minute left, doctor.
You just got to finish now. And again, after that, we just did the hyaloid removal, completed the PVD so that the sub hyaloid exudates are cleared. Gently inducing the PVD here. Completed the vitrectomy and injected intravitreal antibiotics at the end of the case. And this is the post-op 3 weeks picture of the same patient. So just to conclude, post-Jex implant infectious endophthalmitis is exceedingly rare, as per literature report at least. But the real world scenario may be quite different because of maybe lack of serious adverse effect reporting, or maybe apprehension of data sharing amongst colleagues. So a strong vigil after any intravitreal injection is prudent, even if the products have an excellent safety record. And to conclude, in these cases, a low threshold for early vitrectomy with removal of the implant yields excellent results. Thank you.
Thank you. Wonderful.
Thank you. Thank you, Dr. Vishal. Really, you showed very interesting cases. I now request Mahesh sir to quickly add a few points. Sir, I had also had one case. I tried with the cutter. I don't know. I was lucky. Probably it was post 1 month or so that it came out with the cutter itself. The Dex.
1 month.
Yeah. So probably the disintegration of that implant probably would have caused. But here I could see Vishal's video that even with the 23 gauge cutter also, it was very difficult to cut and eat it up. So just wanted to know your way of approach in handling these cases, sir.
Actually, I had only one case, probably 7-8 years back. I presented in Mysore VRSI. That was a big blunder that I gave. Actually, I gave injection Ozurdex in a case of post cataract surgery CME, which was not responding to drops and everything. It was a clear view with cystoid macular edema documented by angiogram. After injection, behind the IOL, this white fluffy thing started. It was a low-grade fungal endophthalmitis. Patient was putting on steroid for a long time, so I thought it is only pseudophakic cystoid macular edema. And after that, the flared up the low-grade endophthalmitis. I lost the eye. Aspergillus was grown. I don't have experience of removing the Osiris, but as he said, in the early stages, immediately after injection, if you are removing in 1 week and all, it is very difficult to chew the thing with the cutter. So I think this is the best method, Vishal's method.
Pramod sir, quickly. Before we
Yeah,
go
I
to
agree
Atul
with,
sir's
I
talk.
think, thanks Vishal, wonderful video. And I think that's, I would say, right way of doing it when you do early stage, because it is slippery, difficult to catch, and 23 port again is much smaller to suck it out, to grasp it basically. So that's why I think I would say 20 gauge is best way to do it. But yes, as it get older, it wall become fragile. Even if you grasp it, it will just crumble there in your forceps itself. And so I think then Srinivas, your technique work that then you have to just chew it up that way after a month or so. Sometime probably all of us have seen even already is broken into 2 pieces. Now, yeah, a couple of things here is, if you are sure you are dealing with bacterial infection, if you know which organism you are dealing with, and you know sensitivity pattern, really is necessary to remove this implant or not.
Yes.
That's one way of thinking about it.
Yeah.
But fungal infection, yes, I agree, Mahesh, because most of the time what you have seen, this steroid, continuous prolonged steroid use and steroid implants sitting there, they present probably more with a fungal infection, and then it become imperative. You don't have choice unless you remove, patient will not respond. So I mean, that is, I leave that question open, because steroid is a part and parcel of treatment when you deal with a bacterial endophthalmitis. But provided you need to know sensitivity pattern.
It might not be due to the implant per se.
Yeah, exactly.
Yeah.
That is
low
also
grade.
what's going on now.
So one more thing is that one more suggestion is that when you try to remove the implant, the Osiris implant, you can put some PFCL to support the macula and prevent trauma. So the PFCL, this implant floats on the PFCL. The implant floats on the PFCL, and then you can grasp it easily without causing any macular trauma and take it out from the ports. So that way you can inadvertent trauma to the macula is avoided. Second, I strongly feel that we should put copious betadine and make sure that there's a sterile, create a sterile atmosphere around the eye when you take these patients up for Osiris. It's not like giving an anti-VEGF injection. Osiris injections are more risky, they're more prone to infections. And often they are diabetics, and often the steroid injections are makes the eye immunocompromised. So I personally feel that whenever I've given umpteen number of injections of Osiris, but I always make sure that I do double or triple the amount of betadine, cleaning of that area of the sclera where I'm going to inject.
Excellent.
And I go in by the valve entry. I go to the valve entry. I don't go in straight in. I go tangentially and then in. That way, it's like the classical surgical entry for trocar cannula. That way, it creates a flap which is self-sealing. And I've till date, with God's grace, not had a single end off. So prevention would be the best.
But wouldn't it become
Thank you.
a reservoir for bacteria if you don't remove it? How could you differentiate it's not involved and leaving it there?
No, the discussion here.
I think the safest bet is to remove it. And one of the patients came pseudomonas positive, and one was sterile cultures. The culture came negative.
Once there's a purulent material, it's best to remove it,
Yes,
because it may not settle. Because the nidus is around the implant, and how it got into the implant, it's difficult to say.
Yeah.
Because actually they all sealed this thing. And actually when you open the seal, you should immediately inject. There shouldn't be even a 5 to 10 minute gap between opening the, make sure that you inject immediately.
Yeah. Thank you, Atul sir. Dr. Chaitra, your last comments, and then we'll go with Dr. Atul sir's talk.
Yeah, so since Bende sir mentioned that we don't really need to remove the implant always, I think somebody else also did. I'm just sharing experience with one RVO patient who had a massive edema, gave her injection. I think about 10 days later, she came back with a bad endophthalmitis, we were not able to remove the implant, come what may. Did manage to do a thorough vitrectomy, but with the cutter, with the forceps, anything we did, somehow we were just not able to, remove the implant. So we just let it be. And not only did her inflammation come down, her edema also resolved, and she's doing very well. So sometimes, probably like everybody discussed, it does work. This is just one patient I've had end off after Ozurdex, and I actually didn't remove the implant.
Sir, what I did, Pramod sir, is in one of these cases, I held the implant in my left hand and completed the vitrectomy, left it and then put it with the oil, because I was little afraid whether the cutter will cut it off. And again, I have to ask the patient to put another 28,000 or 30,000, because when we are not sure whether the DEX implant itself is going to cause the infection and whether that is the source of the infection. Again, it's a debatable topic. Thank you very much. Everybody have given their thoughts and the learning tips. Thank you very much.
Thank you, Srinivas.
Yeah. Chitra, madam.
We shall now go on to our next very eminent speaker, Dr. Atul Kumar, who after a major stint at RP Center as a chief and a professor of ophthalmology, is now majorly into a very successful private practice at New Delhi. And he's going to take us on to a very interesting talk on simplifying macular pathologies. Thank you very much, Dr. Atul, for being with us for this webinar. And I'm sure not only us, many of us around will be learning from you. Thank you.
Sir, Atul sir, you have to unmute. Yeah, now you are unmuted. Yes, sir.
Okay.
Go ahead, Atul sir, please.
Yeah, so, well, I'm thankful to you for having me, including me. I'm entering into the scientific part after a long time. And this time also I requested you to please include me because I was feeling kind of lost. There was nobody to invite me. So, well, the truth is the truth, it's bitter.
No,
and then
senior.
also Srinivas was very nice and he immediately said, yes, sir, we must like to have you. So it felt good that somebody still thinks that I can speak.
Sir,
so
what are you talking, sir?
I know.
Truth is bitter, sir. Tough.
No. Yeah, you have been a role model to many, sir. Please go ahead.
So when it comes to politics, it's different, sir. Okay, sir, I'm going to talk about simplifying macular pathologies, mostly surgical. I have limited time, so I have cut down my presentation to such that I fit into the time. Otherwise, it shall not be correct from my part. So I shall talk about how I approach certain diseases of the macula. I use the Ingenuity because I'm very used to using the Ingenuity, and if you can see the eyepieces have been removed and a high definition microscope has been put over here, and this transmits the image onto the Ingenuity screen, and the Ingenuity screen is large enough to give me, because it's a digitalized screen, so it gives me very wide magnification, very high magnification, and very wide zoom. So what I can get is a very high field and also a magnification. It's tremendous. So it's much more than the microscope. So the field is there, the magnification, I can pick up small breaks. So this is the place where I work. This is a small video taken off the Ingenuity screen. I'm using with a 27 gauge cutter because there's a fibrovascular sheet in a diabetic. So you can see the sound on the video. It's been done so that I found I could insinuate between the membrane and the cutter. And there was enough cleavage space, and I could create a kind of a segmentation. And as I went along, I could create the segmentation. And I'm just telling you that it's quite clear. The picture is very clear. So, yeah. So I'll stop at this, and I just say that we've published this the heads up viewing in, because we were among the first to use the Ingenuity in India in 2016. And the ergonomics have been seeing on the WhatsApp groups, though I don't go much on the groups now. But I can see the ergonomics plays a big part for vitreoretinal people, also for the cataract, cornea, refractive people, because they're always bending over into the eyepiece. Also, they're bending over to see the eye. So it really helps to keep your back straight and your cervical spine in the correct position. So I'll start with the, I've already started, but this is a compound myopic macular schisis. We must understand this: a greater than 6 millimeter axial length or 31 millimeter 6 diopter axial length or 31 millimeter pixel length. Usually these patients have pathological myopia with the compound schisis can be there, inner layer schisis and outer layer schisis. This can be very well be the picture. And the traction is often because of the taut ILM, the taut vitreous, the foveal schisis, and there's a posterior staphyla which acts on the opposite direction. There's a remnant cortical vitreous. He even says retinal arteriolar traction on the macula plays a role. So there's a lot of work done in Japan, and where they have a lot of high myopia. They run in Tokyo, the School of Medicine, they run a high myopia clinic. So we reported this in 2018. So this is a case recently I saw in 2022 at the news center. It had 35 millimeter axial length, of course, so that won't change. But she's quite okay. But then she suddenly developed this multiple layers of schisis, which is kind of increasing, and there was a serious detachment at the back. And the vision had dropped 2 lines. So we immediately told her that you would require surgery before she develops more detachment. And when she had a couple of lines of visual drop, she agreed. Probably patients are very demanding. They want to have a reason. So when she said, yes, my vision has dropped, I'm feeling more blurred. So we did this. So you'll see, this is the fovea. This is the fovea over here, the yellowish, the xanthophyll pigment over here. So I'm just starting. It's a little difficult to see because the eye is 35 millimeter myopic. The instruments are barely reaching the posterior pole. So what I'm trying to do is I'm trying to grip the stained ILM and the posterior tissues and trying to keep it all around. And, I'm working with holding the forceps at the one edge so as to get the maximum amount of the forceps inside the metal part. And then you see, I'm kind of pulling and tearing the ILM towards the center. This helps me to keep the center intact, and there might be a little ooze, but then it's all in the game, and it actually, as long as you can get the traction off the center. So I've got the traction off the center, and over here the traction's off, and I've got the rolled out ILM, which is now only attached in the center. So I have the IOCT on my Lumera 700, which showed even a CNVM over there. So this is the picture, and I just want to tell you that this is a very satisfactory and the factory procedure. It's very challenging, but I found it very satisfactory. Now she's come for a follow-up. Our OCT shows the thesis has gone down tremendously. The macula holes, you all know. Standard macula holes I'm not talking. So in this quick lecture, I just told you failed macula holes. We did a surgery, and lo and behold, we found, unfortunately, that there was a failed macular hole, and the MHI actually come to less than 0.35. It's greater than 0.5, and it's supposed to be a good prognosis outcome. So you can see here that what happens is a short clip of 10 seconds. I'll edit the clip because I've already edited these videos, but I think with lack of time, I'll have to further cut short the videos. So this I'm putting the Aravind G dye, and of course they use their PFCL also, and thanks to Arvind, they give us the products. They're very well based in Delhi. We have Orolab products here. So I put this thing, and I put some extra BVG under the PFCL because I want to stain whatever ILM was left behind, because this is failed. So already the ILM has been peeled. It was done elsewhere. So I just want to see how much ILM was there. So I just one sec, I'll come to the magnified picture with the Chalam, KV Chalam's lens. I am very fond of using KV Chalam's lens. With the Tanos are tended to make the hole a little bit more narrower. I've got it because sometimes synechia between the retina and the underlying RP. So I try to make it into a slit. And then from the edge, I've got the center has no ILM. So from this edge, I've got the flap, and I put, so there's a small pedicle over here. I'll show you how I got the pedicle here. Small pedicle I've got here. From the periphery, I create a pedicle, and I've bought this pedicle here. I might have to tear this pedicle to bring it right onto the center. It's difficult to bring all the way, and you do it under PFCL. Don't try to bring it out of PFCL, because if you do, then it'll never go back. So just tangentially push it, pull it along, and let it stay there. This works very well. Okay, so this patient did extremely well. This is a post-op day fun. So another thing about the macula is you get a detachment with a configuration, high myop, configuration of retinal detachment like a bulla sardi, but inferior bulla sardi, with no detachment in the superior quadrant. There is a high possibility of a macular hole RD. So we reported this way back with a resident who is now in UK, Sana Tenwala. So this was a very interesting feature that we found these patients often had macular hole. There was no peripheral break. We hunted, we never find a peripheral break. It's a macular hole RD. So it's again a part of the macula, which is, sorry, I'll just show you the video, short video, because it's important. So this is the kind of a picture it was, pathological myopia, and now with the fluid going through, as the fluid is being switched on, the fluid's gone through, it's gone up in the superior part also. So I just wanted to induce PVD, because until you induce PVD, these RDs cannot settle in any way. So it was a little tough to, because thin retina, and it was kind of liquefied vitreous, and all the BSS was going into the subretinal space. So no found vitreous. So it was tough to make sure that we don't tear this extremely fragile retina. So what we did was we tried to, as with controlled suction and keeping the cutter port upwards, I tried to create a PVD, and you just see there was a PVD creation. So, but we got to go a little slow. So I'll just show you 1 second. So you see, this is the hole. You see, this is a hole, and we kind of created a slightly, we aspirated the fluid from the hole. So we settled the retina a little bit, because we aspirated fluid from the hole, SRF, or whatever you can say, vitreous fluid. So afterwards, we put some brilliant blue G dye, which is to basically stain the ILM. This is the very special forceps which has, from Alcon, it's called the shark skin forceps. I didn't find much difference from it compared to the other ILM forceps. So what I'm trying to do is I'm pulling the ILM right over the scleral crescent, and the IOCT will tell me, because the IOCT is very important in these myopic surgeries. The IOCT tells you whether the hole has covered, the flap has covered the hole or not. So it's very tough, because the hole is hardly visible. So it's sometimes an approximate game, hunch that you got a hole closed. So you can see here, we've kind of closed the hole. So that's one thing. And second thing I'll talk about is the optic disc pit maculopathy. Is a herniation of dysplastic retinal tissue. Is going all the way to the subarachnoid space. Two accepted theories are the vitreous tumor and CSF. And you can get a very good picture or image from the OCT. So you can do ILM stuffing, but they're saying that it may create macular holes. So you can do PPV with the installation of platelet-rich plasma, which is also an alternative. I put scleral grafts. Some people do that, but we getting good results with platelet-rich plasma. So these are the kind of holes. You get a multi-layered PVD. This is ILM detachment. The multi-layered this thing. Separation of the retina. It's not like a myopic foveal schisis. It's multi-layered schisis. It's not a one layer. It's multi-layered, unlike a myopic foveal schisis or MTM. So this was after the result of giving platelet-rich plasma at the hole, the pit. So you have a pit here. We'll show you a short video on this. So one very important thing to do in the optic nerve pit cases, they do the PVD induction. PVD induction by itself reduces the traction on the part of the pit which communicates with the macula through the vascular channels. So the vascular channels actually transmit fluid into the macula and cause a maculopathy. You get optic disc pit maculopathy. So optic disc pit maculopathy is classically multi-layered schisis, and it transmits through the pit. So what you can do is that people said laser and all that, but it's a little outdated. So it's a little destructive. So what they've been saying is that you can put autologous serums, flaps, lots of things have come. So we put this platelet-rich plasma. It's a concentrate from the serum, from the blood of the patient. Many labs make it for you. So we put this over here, and we got this picture. It takes time. 4x60 with the inner lamellar hole with multi-layered schisis here, schisis here. You see, it's kind of settled down, but it's not totally settled down at 1 month. Vision's improved from 4x6 to 6/24. So a little ups and downs, but it does settle down. It's not complete. So you got to tell the prognosis to the patient. Last thing I'll just tell you before I finish, because extramacular bleeds often with PCV eyes, we get to see this, and also with RAM. But PCV eyes are very common here, and I get some cases. So I use recombinant TPA as in the concentration of 12.5 microgram and 0.1 ml, about 3.3 cc. Avastin 2 double the strength, and the air bubble. I put it in a 2-clun syringe with a 41 gauge needle, cannula, which is used for actually translocation surgery. And we have some publication. This is a massive bleed which came to us recently. We kind of gave up. Some people say you can do a peripheral retinotomy and do. I thought that's very destructive. So once you do a peripheral retinotomy, there's a lot of PVR and all. You have to lift up the flap and then remove the clots. So I kind of went conservative. I totally agree that peripheral retinotomy may have been a good option, but I like to create the PVD here, as I always do for every case. I create the PVD, and once the hyaloid is lifted up, then you're sure you're onto the retina, and once you're onto the retina, you can. IOCT tells you where the PED is not there. If the PED is there, I won't enter, because PED is the area, the sub-PED space. I'm not going to put drug, because sub-PED blood is not going to move much. I'm going to choose a side which is subretinal bleed. So I chose a side which is subretinal bleed, and I entered. I know the video may not be so apparent to you because the OCT is coming in the way, but I had to show you the OCT too, because the intraoperative OCT. So we injected, and we had a little choroidal also, but this patient did extremely well. And this is a amount of extensive bleed he had. So this was the kind of post-op picture at 10 days. And this is a disc, this is the macula, the whole blood's gone down. So patient is done well. He's got blood in the periphery, but his central blood has gone down. We actually injected 2 places, so as to make sure that we had enough TPA, recombinant TPA. So it did help. At least the retina was on, and we put C3F8 gas, and there's no prone positioning in this. You just put the patient propped up, unlike intravitreal TPA. But intravitreal TPA also works, but this kind of massive bleeds, I think subretinal TPA will work better. Thank you so much.
Thank you.
I just 3 talks only, 3 topics, because the time I think I must have overshot.
Thank you very much. That was a terrific talk, and I enjoyed every minute of it. And
thank you, ma'am. Thank you, ma'am.
Where is Srinivas? What happened to him? Dr. Pramod, could you take on the discussion? Srinivas seems to have gone.
Yeah, excellent.
No, I'm here only, madam.
Yeah.
Atul sir, thank you very much for that wonderful presentation. I think I believe in what sir did. In few of my cases in failed macular hole, where they call it as the open door sign, where you see the tall holes, the edges of that holes, and I try to piece that. But unfortunately, in 2 or 3 cases I have tried, it never closed. So I think it's the right thing to drape off the ILM over those cases, and then we see a good. Otherwise, what I feel, sir, please, I need your thoughts also. If it was a gas, then probably the closure rate would have been a little more better, because as we all know, gas exerts a highest pressure of 70 dynes per centimeter square as compared to the silicone oil, which exerts.
I put gas only.
You have put gas only. Okay.
Yeah,
so
second time.
I think that is.
I put a long time. I put C3F8 long acting.
Yeah.
First time it was put SF6 somewhere else. So I give C3F8 this time.
And one more question, sir, regarding your myopic foveoschisis. Did you have any experience of having a MAC hole in these cases while doing an ILM peeling or later after
No,
doing,
sir. No, sir.
especially when there was staphylomatous eyes in
No,
those
sir.
cases? What are your tips how to go about in such cases when there is a staphylomatous eyes with FTMH where you don't have the macular buckles to be placed?
Make sure that you're only peeling off the ILM. Don't pick up tissue. If you pick up retinal tissue, just drop it. Go back again. It's a patient job, sir. Patient job, it goes slowly and you'll find the ILM just lifts up separately. So it takes a little while. I mean, you can't be in a hurry. I mean, no meeting or no, seminar or AIOS political meeting or something. You got to be very, very into science. I mean, it's different. It takes an hour or so.
Pramod sir, you wanted to tell something?
No, that's fine. So I think excellent cases, sir. Nice to see Dr. Atul Kumar after a long time. Really happy to see you. So I think he explained very well. The practical difficulties is one thing is like now subretinal hemorrhages. Getting TPA is not that difficult, but what to do with the leftover TPA, because then for one patient the cost is huge. Those are having multi-specialty hospital, probably they can get from your cardiologist and use that one. But as a standalone hospital, probably it's difficult. Previously, we used to store in -70, allocate it small ampoules. And for each case, we used to use that one, but I think that become difficult now. And what literature suggests, yes, very massive hemorrhage. In generally, prognosis is really not that great, though you can take out the heme. But
improve his vision to such, at least ambulatory. Make it 624, 636.
Yeah,
he's happy with
patient
this.
Definitely is worth attempting. But result-wise, whether intravitreal with a gas and giving subretinal also probably, and including even trying only pneumatic retinopexy, more or less not much difference when you see as per the literature. But yes, I agree, when hemorrhage is quite large enough, and one-eyed patient definitely is worth attempting this type of surgery.
And Pramod, one more thing. One more thing, that these PCV eyes who bleed, they have a very high notorious tendency to bleed again and again.
Yes.
So after the surgery, after a month of the surgery, I re-inject with Eylea or Avastin or ranibizumab because they tend to rebleed. So you have to keep the retina quiet in attached retina. Now the blood has kind of moved downwards. The blood actually moves down. It doesn't get absorbed.
No, I agree. Yeah, that's what.
Yeah, so I have a patient who's been receiving every monthly injection. So I'm dearly looking forward to PDT. I really feel PDT should be there for all of us. I get so many CSC patients who are recurrent CSC, bank officer who's working into loans. Just today he says, I'm terribly into mental stress, lack of sleep. He's got multiple areas of CSC recurrent. So the ideal candidate for photodynamic therapy. All of us retina people here, Pramod is there, Srinivas is there, Chaitra is there, and Rajiv is there. We can all work for such things rather than spending time on the useless stuff.
Yeah,
no, I think we need to tell Appa Swami to just come up, or this RO lab to come up with something.
RO lab to come up with some photodynamic.
Because
we are trying in our lab.
Is trying.
Yeah, because we have so many patients,
I agree.
Even PCV, they can't keep on taking Eylea. It's so expensive for them. Even if they got insurance, the insurance is very hesitant to give them again and again so much money,
I think probably pharma industry also is involved in not making sure that PDT is not available for us.
Yeah, we are doing PDT actually. We are doing PDT.
Are you doing, sir?
Yeah, in Arvind Coimbatore, we are doing PDT.
How do you get the dye, sir?
We are getting the dye from Germany, and we are doing it, though it's a limited availability, but we have so many patients waiting. We are doing it on a waiting list basis because as the drug comes 3 or 4 vial, we do a half dose PDT for all the CSR patients who are desperate with chronic CSR, nothing works. And the kind of patients which you are talking about, Atul sir, this PCV post-vitrectomy or breakthrough vitreous hemorrhage or submacular bleed, once you do vitrectomy, injections don't work any further in these patients. So
So
when
you have the
do
PDT laser. You have
Yeah,
the PDT laser.
we are doing a PDT laser. We are having since
The
15 years.
589 nanometers.
Yeah, the size laser.
Yeah.
And
It's an old one.
The same old one we are using still. Yeah. And
So can you send me the address of the dye from Germany? Sir?
Yeah. We'll
I'll
let
be
you
keen.
know. Yeah, I had actually passed to LG sir and Muna madam
George, I
also.
have your number. I'll get after you.
Yeah, we will definitely.
You're a good friend of mine.
So
George is a good friend of mine.
So we are doing it, but limited availability. But we are forced to do in many conditions like this, which you presented, because surgery is not the end of the story. We do a gas displacement and give an anti-VEGF. Because of the non-availability of PDT, we rather stick to what Pramod sir mentioned, only gas displacement and anti-VEGF. Displace the blood as much as possible and continue, because you have the vitreous there. We can continue with monthly Eylea injections and do an angio later, ICG angio later, and if required, you get time to
George,
do
only thing is the cost of the Eylea is disturbing to the patient. The minute I tell him every month you need an Eylea injection, he gets very upset.
Yeah. Post vitrectomy.
So I'd rather give him a
at least
PDT and get over.
Yeah. Very true.
So I'm waiting for you. You also have my number. Please message me that Germany number.
And to the point Dr. Joshi was mentioning, Dr. Atul showed the macular hole with that open door kind of standing up. It depends whether it's an early failure or late failure. If it's an early failure within 2 weeks of surgery, mostly such conditions would be somebody would have used a short-acting gas and inadequate gas tamponade. So in such cases, early failures, mostly repeat fluid air exchange and gas would suffice. And the kind of surgery which Atul sir showed, it is reserved for these late failures, the ILM transplantation and under the PFCL.
So this is a doctor who was running a nursing home, and the visual acuity was very compromised when the hall failed.
Yes.
So she came running and panicky. She says, my vision is not there. I'm a surgeon. So I had to quickly do the surgery and make sure she gets a absolute success, because once I put in the ILM over there and kind of give it a little gentle massage, it sticks into the defect well. And now she's recovered well to 6'9", 6'12", and she's seeing everything clear. So I'm quite happy. So that's what I did.
Thank you very much, Dr. Atul. Do stay on with us and keep your very relevant tips. We shall go on to Dr. Neha. Dr. Chaitra, I'm calling before you. Probably she has to go somewhere. And we'll have Dr. Chaitra Jaydev.
No, I think Dr. Neha will be presenting and then Dr. Chaitra, madam.
Oh, you didn't tell me that. Okay. Sorry, Dr. Neha. I was given wrong information by my member ARC. We'll deal with him later.
No. They changed it themselves. They coordinated
Please
themselves.
don't scold Dr. Srinivas because of me.
She's a director and senior consultant Vitro Retina services at TetraView Super Specialty Eye Center. And she's going to show us something very unusual vascular occlusions. On to you.
Thank you so much, Dr. Chitra, and thank you, Dr. Srinivas, AIOS, ARC, for allowing me to be part of this, very, very interesting webinar. It's been some time with the physical starting that, we've done a webinar. It was an absolute pleasure, of course, to see Dr. Atul after so long and to hear him speak. So my case is very short, but I'm presenting it because it kept me up all night and I'm still thinking about it. So I hope somebody will solve it for me. This was a 52-year-old female, and she was a hypertensive and diabetic controlled on treatment who came to me with decreased vision in her left eye since a month. Her right eye was normal with a visual acuity of 20/20, and this was her left eye. She had been diagnosed elsewhere as a hemi-CRVO and referred to me. Her visual acuity in this eye was 20/60. And this is all that there is in my case. I would, both eyes anterior segment was unremarkable. So I was quite baffled by the level of the occlusion, which would lead to this kind of a clinical picture. This is an enlarged view of the disc and the vessels. The OCT was pretty straightforward. It showed subretinal and intraretinal fluid, and I did an octa as well. And this was a 9 mm octa. It didn't give much information because of the hemorrhages, and I didn't perform a fluorescent angiography either. So she's received 3 injections of anti-VEGF till now, and she still has residual fluid, so that might continue. But I wanted to ask the esteemed panelists what kind of occlusion would present this clinical picture, and where we would fit this case in terms of prognosis with the BRVO, with the CRVO, or with the hemi-CRVO. Management, yes, for now it's anti-VEGF depending on the edema, and then once the hemorrhage is clear, I'll proceed with an angiography. So I had some other cases, but I think we are short of time, and Dr. Chaitra has to also present quickly. So I'll just end it here.
I think, Dr. Neha, you can present your second case also. That also
Okay.
looked interesting. You can quickly go ahead.
Okay, sure. It was just for time that. So this was my second case. He was a 31-year-old male and presented with decreased vision. He was a young hypertensive, complained of sudden loss of vision in his lower field of vision since 3 days. There was no history of trauma. Right eye was unremarkable, 20/20, and here is the left eye, you can see 20/200. So there is no such thing as a hemi-CRAO. This was a little older case. I think I saw him about 2-3 years back, and but this very much looked like a hemi-CRAO. So this was the right eye, like I said. Fluorescent angiography, it showed delayed venous filling. And here you can see these were the arteries that didn't fill up, and there was some vascular staining along the edges as well. And OCT showed inner retinal hyperreflectivity and thickening corresponding to the whitening on the clinical picture. So this was another baffling case, which I actually have a folder of mystery cases in which I keep putting these cases. And again, I would like to have the comments of the panelists on what they think could have led to this kind of picture.
Thank you, Dr. Neha. It was really interesting case. But in this, along with the supratemporal, you also have infranasal artery blockage, is it? Along on the FFA?
No, it was not. No, this one you are saying.
Yeah.
No, this was just delayed filling. This is the venous filling over here. I have the other pictures also. I'll show you. 1 second, if you just. I need some time.
No problem. Until then, we can start the discussions.
Yes,
you can
I'll just take those out once.
I request Dr. Raju sir, are you there?
Yeah. I was going through your presentations, Dr. Neha, interesting cases. There is a publication in British Journal in 1966, wherein they described these anomalies of branching. And one of the things is trichotomous branching. Other is triconfluence, as far as the venous branching is concerned. Probably one of them, wherein the hemiretinal vein occlusion that you showed probably had a triconfluence type of a branching, and it got blocked there. That's why it's going above the line there. That's what we can explain. Except for the vascular anomaly, I don't think there is anything else that can explain the findings that we have here. And thank you for the nice cases.
And what about the second case? That also for the hemi-CRAO?
Hemi-CRAO, I didn't look at it. I was trying to see the other case. So I think that also must be having the same kind of vascular anomaly only. I saw the other case wherein there is one of your third case, I think. Third case also was having a branching, which is anomalous branching.
Anomalous, yeah. And actually, if I can just share my screen and show the remaining pictures of the FFA here.
Of that second case, right?
Yeah, here. So here.
Yeah, now we see that feeling.
Yeah. So I probably took, and this is the supratemporal area, and this is the intranasal area. So this case actually I saw in 2017, but it still hasn't left my mind.
George, sir, your thoughts, because the
the
intranasal vein
sec-
also looks like a delayed filling.
Yeah,
and the
there was delayed
supratemporal
venous
artery is
filling.
blocked.
Yeah, there was
So
delayed
multiple
venous filling.
combinations are happened in that.
Yeah, Neha, I think your cases are interesting, very interesting cases. The second case looks like your emboli has moved distally, and most of these BRAOs, CRAOs, emboli related, or in the adults, what we see, many of them are partially reperfused. If you see that the angiography, there will be a delay in arm retina or arteriovenous filling. But it is not a complete occlusion, like how sometimes what we see in vasculitic or occlusive vasculitic, it will be reperfused. So sometimes those CRA or hemi or whatever, that BRAO, that emboli might have moved distally and causing a non-perfusion there. I think it's looking like that in your case. And as very rightly mentioned by Dr. Raju, that only explanation for, generally it respects the horizontal raphe. We all know that superior and inferior horizontal raphe, these the artery respect that. But only explanation is what he rightly pointed out: either an anomalous vessel at the disc coming out, the division of the anomaly in the division of the, or the area where the artery crosses the vein. They have a common adventitious sheath. In case of your CRVO, where the artery crosses the vein, usually it's post-laminar. So whether it is at the area of bifurcation into superior, or see, that is the only explanation that we can have, because it doesn't respect the horizontal raphe there. So,
yeah, so 1966, and that means almost 40 years, and 2 cases is, I think, quite rare.
Yeah,
about the CRAO, but the central retinal artery doesn't actually branch that way, the way you don't get hemi CRAOs the way you get hemi CRVOs. So I'm not sure if the embolus moved like you are saying, because I don't know, the inferior
you have only a peripheral ischemia there, isn't it? The one small area at a distal end of that artery. That's why I think it's like as if it is moved and reperfused. Actually, that's nothing related to the zone of involvement. Even we have published one case of pediatric pediatric BRAO in a 7-year-old female that also did not respect the horizontal raphe. The pictures must be in the publication actually. That was not exactly in the, it was just going nasally above. So we didn't have an explanation to that, probably as an anomaly in the vascular division or dichotomy or trichotomy of these.
Yeah, because the whitening is quite well demarcated. It's exactly horizontal, the retinal whitening. And even an OCT through the nasal area, I have that, I didn't put that, also confirmed that there was ischemia, there was inner retinal hyperreflectivity, there nasal to the disc also superiorly. So
thank you, Dr. George sir, and thank you, Dr. Neha, for presenting those wonderful unusual cases.
Very interesting cases. And we go on to our next speaker, Dr. Chaitra Jaydev, who heads the Vitreous Retina Services at Narayan Nethralaya and also is the joint secretary of the AIOS, and she has another interesting case on diabetic retinopathy for us to see.
Yeah, good evening, everybody, and thanks, ma'am and Srinivas, for this opportunity. Today, I'm going to cover 2 interesting cases which we see in day-to-day practice, but sometimes don't pay too much attention to. So this is both about diabetic retinopathy and, more importantly, diabetic macular edema. This is my first case, a 54-year-old gentleman with moderate NPDR and no significant macular edema, who was on regular follow-up. I used to call him every 6 months, and he was doing, quite well. And this was how his picture was. And he came, and these were his OCTs during his follow-up, and was fairly okay. And he was in also very fairly good diabetic control as well. He came about a couple of months ago saying that there is a progressive blurring of vision in both eyes, and this was of 1 month duration. He initially attributed to poor sugars that were not, a little above his usual average. And this is how he presented to us. So in first picture itself, I thought, there was something wrong with him. And then even his edema, if you see, doesn't look a typical a macular edema that you would see with sudden worsening in diabetics. Vision was 6/9, 6/15 in the right and left eye. You're seeing the usual cystoid macular edema, intraretinal and subretinal fluid that you would see in any diabetic as well. Since the blood, distribution, the hemorrhages looked a little odd, I did go ahead and do an angiography. There were microaneurysms, non-perfusion here and there, cystoid macular edema in both eyes, and no clear neovascularization. Hence, I thought let's get him investigated, and found him to have a very low platelet count. This is when we saw him in our hospital itself, just did a peripheral blood smear. Counts were low, and the patient did not really give any history of fever recently or any other systemic issues despite questioning him. So then we went on to send him to a hematologist for further evaluation. We were a little worried, what's going on with the 16,000 count. That is when he was confirmed to have a condition called as HIV-associated thrombocytopenia. And he was treated with romiplastin and started on heart treatment. He was under the care of a physician for over 2 months. In fact, he was admitted in the ICU for care because the platelets were still continuously dropping. Unfortunately, even his wife was detected to have HIV, and his son is a doctor, and he also just got to know. He returned with the worsening of his visual acuity at 6/18 and 6/24, and this is the picture he presented with. You can see diffuse retinal hemorrhages in all quadrants, several small perivascular exudations, and you can also see these retinitis patches with low-grade vitritis in both eyes. And this is how his, STOCT was when he came back to us with significant thickening and subretinal fluid as well. So clinical picture of HIV retinopathy, impending possible CMV retinitis here, coexisting moderate NPDR and macular edema. So it was, a lot of things going on. Hence, we gave him a combination of intravitreal ganciclovir, dexamethasone, and bevacizumab in both eyes, hoping, to give him some amount of improvement because we had already lost a lot of time. A total of 4 intravitreal bevacizumab injections in each eye was given over 6 months, 2 doses of ganciclovir and 1 in the left eye. So this is how he gradually improved over 6 months. His retinopathy and edema significantly improved, and vision came to 6/6 in both eyes. This was how he was, at his final checkup when we recently saw him. So diabetic and HIV retinopathy can coexist and should be suspected when we don't see great response, or we see a sudden worsening of the disease, or we see atypical retinal features. Then we definitely have to check these patients for other systemic issues. Retinal microvasculopathy of both HIV and diabetic retinopathy are very similar, and they need to be correlated with the systemic status. And one is known to cause worsening of the other. And also sometimes the treatment for one can worsen the presentation of the other disease, so when they coexist. So shall I complete my second case, or we're going to break for discussion?
Yeah, go ahead
now?
quickly, please, ma'am.
Okay, so this is my second case. This is a 64-year-old male, blurring of vision in both eyes, left more since a couple of months. He also had a right-sided headache, a shoulder pain, very vague symptoms, which we really didn't pay much attention to, which we, on retrospect, we probably should have. He was a controlled diabetic for 5 years and hypertensive for 4 months. So this is his clinical examination. Vision was 6/36 and 6/24, and he had a cortical cataract. Otherwise, everything was pretty much normal. So this was his presentation. This is the right eye, and this is the left eye. Here again, we thought something was wrong. We even sent for investigations, but nothing much came about, in the first visit itself. So this is how his presentation was. You can see that the atypical presentation of the subfoveal detachment there. The subfoveal fluid also looks a little odd. So this was the presentation. Then at that point, since we got investigations done locally, he got some blood tests and came. At that point, we thought, okay, it still could be a severe NPDR, and we went on to treat him. This was on and off because despite medication, you can see how much more the fluid has increased over the entire year that time for both the right and the left eye. Finally, we were really lost. We didn't know what to do. That's when we sent to since he did not respond over a year, we sent the patient for a repeat blood test and sent him to an hematologist. And this is when he was diagnosed to have a lymphoma. A bone marrow biopsy was done. So this was rather unfortunate, but luckily the patient is still doing well. He does have this condition called as paraproteinemic maculopathy. So again, very atypical edema or sudden worsening is something that we should keep a lookout for. He was under the care of a hemato-oncologist for a year, and then in remission 13 months later, he came to us. He had poor vision, but thankfully it was only because of cataract. He underwent surgery in both eyes with a lens implantation, and his vision was 20/80 and 20/60 in the right and left eye. Of course, because of that, over years of damage, this is how his OCT pictures looked at final check. So paraproteinemic maculopathy is typically bilateral systemic pathology, hypergammaglobulinemia. Immunogammagulopathy such as SLE, Waldenstrom's, and multiple myeloma can cause it. Basically, there's hyperviscosity, stasis, and hypoxia of the endothelial cells. And this causes deposition of the immunoglobulins and subretinal fluid accumulation due to the osmotic gradient. So resolution of the submacular detachment requires treatment of the underlying pathology. It is slow and most often it is incomplete. And decreasing the blood immunoglobulin levels is the primary goal in these patients. So this is one paper that shows that long-term visual prognosis in these patients is actually quite poor. Thank you so much.
Thank you. Very interesting, Dr. Chaitra. So discussions.
Very good presentation. So it opens
Thank you,
our
sir.
eyes to, because we often see cases of diabetic retinopathy with certain worsening, hemorrhages all over, and we don't realize that it could just not be diabetic retinopathy, it could be something else coexistent. So comorbidities, it's important to get a full blood test, including the BT-CT, and get the HIV, all the parameters, make sure that the patient doesn't suffer from any other disease, because we just concentrate on the diabetic retinopathy. So you got to spread out and, kind of broaden our this thing and get the patient examined and by a hematologist, and also by an oncologist if required. But the hemato-oncologist would be the ideal.
Yes.
I'm sure a lot of big hospitals have such facilities all over the country, and the patient can always get it done and come back to us.
Thank you. Thank you.
Very nice cases. Very nice cases.
Yeah.
Yes, Dr.
Rajiv sir, I
Yeah.
had one question quickly.
Chaitra fully deserves the IGO editorship.
Thank you, sir.
I'm quite blunt in such things.
Thank
I
you,
don't
sir.
care.
Thank you, sir.
Yeah.
Thank you. Rajiv sir, there was the 4 reports being said after giving DEX implant in an immunocompetent patients also, they have been reported to have CMV retinitis. And in few of the cases, there are reports that increasing the antiviral and increasing the dexamethasone also has helped in treating these cases of viral retinitis. So when both these the contradictory things are there, and Chaitra has beautifully showed, and the patient fortunately responded so well, especially that second case after giving the dexamethasone and giving the ganciclovir. So I just want to know your thoughts on these cases, sir.
Yeah, just I will tell your answer, but I had 2 comments which I would like to tell.
Yeah,
the
please.
Beautiful cases and 2 important take-home messages. There are 2 red flags in diabetic macular edema. One is the moment you see these hemorrhages which are increased, sudden increase in the retinal hemorrhages.
Yes.
Actually, the cause is anemia. Usually, HIV thrombocytopenia also is because of hemolysis. And the most common thing which we see is because of CRF, they get anemia and they get these anemic type of thing, though I could not see any Roth spot in that. But that's something you should immediately, the moment you see increase in hemorrhages, think about anemia, hematologist opinion, and I think very well managed. And what you rightly said that on follow-up, the patient, another thing which happens because this patient had HIV, even on heart therapy when they are on, they develop thrombocytopenia sometimes. So I think we really don't know whether he was already known case of HIV on heart, developing this hemolysis, causing thrombocytopenia and anemia both. And answer to your question, definitely ganciclovir was more important. And steroid, as you rightly said, it's controversial whether to use or not, but definitely ganciclovir in the later stage. The second case, again, when you see a disproportionate neurosensory detachment, in a case of diabetic macular edema, always think of multiple myelomas and paraglobinemias, because that is, and especially when you see the overlying neurosensory retina is more compact. If you see your follow-up, you don't see so much of cystic spaces, but you see a disproportionate SD. So again, that's...
So they are called as SMD. I think that's the main thing. So we don't call them as SRF. We don't call them as neurosensory detachment. They are called as SMDs.
So
These are very different.
Serous macular detachments, and you are seeing the overlying. You don't see that much of diabetic change there. You see the overlying retina is more compact. Unlike in renal, where you see a neurosensory detachment with a cystoid edema along with it. So I think both the cases, she showed two red flag signs: disproportionate neurosensory detachment and sudden increase in hemorrhages. Beautiful.
So this patient actually went to Tata Memorial, so he had, then his son-in-law used to bring him, surprisingly, so much care. And when the minute I saw that there was weight loss is when I realized, this is not, despite our locally, wherever he got it done. So he was treated in TMC for almost a year. Only then he kind of came back. He's still on follow-up with me. So it's really good to know that both the patients are doing well.
Dr. Chaitra,
Thank
very
you.
good cases.
Just
one comment these diabetic patients, even we have seen, when you see that typical retinopathy which you showed, as Dr. Raji was also mentioning, actually Hyra had mentioned very long back as venous stasis retinopathy. These are looks like CRVO. This is not actually typical CRVO. These are bilateral and splinter hemorrhages. Venous stasis retinopathy, when we see, it should, and with serous macular detachment. We have seen in diabetic setting many patients with multiple myeloma, and your case is the second commonest, that is Waldenstone macroglobulinemia. So in this case, anti-VEGFs we have tried, it doesn't work. Either plasmapheresis or they undergo chemotherapy, that fluid settles actually. So one take home is no anti-VEGF therapy, and systemic treatments take care of the serous macular detachment as well as the venous stasis retinopathy.
Thank you, sir. Thank you. Mahesh, sir, any last comment you have, or you can go ahead?
No, non-responsiveness to anti-VEGF, we should always think about all these conditions. One or two, absolutely no change. And when there is a disproportionate fluid in the macula, we should
exactly. Dr. Chaitra, when in that 2017 slide you showed that IVTA giving also, you show that macrocyst was
horrible. It was, yes, it just kept growing up.
And it was just growing up. I think that all are the alarming signs.
I think the worry was that it doesn't open up or rupture. It was so huge, the fluid. I was worried that the pressure might cause the macular hole, like a volcano effect. But anyways, he settled down now. He's happy with his vision.
And the first case, the moment you see increased hemorrhages, send to a hematologist if you don't like.
Yeah, luckily we got that early, and 16,000 was itself a red flag. Yeah, thanks, ma'am. Thanks, Srinivas. Thanks, everybody.
On to our next speaker, Dr. Divyansh Mishra, who's a senior vitreoretina consultant from Shankara Hospital, Bangalore, and he has another interesting case for us to see. On to you, Dr. Divyansh.
So good evening all, and thank you Chitra madam, and thank you Srinivas sir. Thank you AIOS ARC for this opportunity. So a lot of learning and very interesting cases. So I start my presentation and I have titled it as Fitful Retina and its Gautiers. So just to mention what does that mean is to look very abnormal and ugly. So this is when the whole story starts. This is at the time of presentation in 2018, where the right eye, the patient had presented as a CNVM. In the left eye, there were some yellowish colored lesions. But when we see an OCT, we could see that there are some very shallow PEDs, which we can see over there, and which was along the disc. And there are some intraretinal hyperreflective materials or probably hard exudates. So right eye was a very clear-cut presentation of a CNV where we wanted to treat it. And after treatment, as we can see in certain cases, as we do see that even after the best treatment, we can see there is some scarring at the fovea with a lot of loss of outer layer and a lot of SHREM, what we can see, and PEDs, which has multi-layered. The left eye remains to be coiled. This is 1 year still down the line when we have injected right eye with 5 anti-VEGFs. And this is even after a lot of pursual, we can see that the scarring is increasing and the vision, which started from 624, has dropped to just finger counting 6 meters or so. Octa, as in this case, we can see the right eye showing more like a dead tree kind of an appearance, but in the left eye, there is that a quiescent CNV or a PCV or an MNV, which is persisting which is still in the sub-RP space, and there is no structural fluid which was seen in the structural OCT. And the vision was also 6/6 and N6. So that's why we were observing as and when we were seeing the right eye or treating the right eye. So this is over 2 to 3 years with the maximum treatment of right eye, 10 injections over 3 to 4 years. As you can see, it has gone from bad to worse. Left eye was somehow holding, and we were always scanning the left eye. And suddenly in 2021, probably this is around November, when she presented with some kind of an hemorrhage. Because that was her better eye, she told there is some change in the vision. So as you can see in the photograph, there is a very mild hemorrhage in the superior temporal area of the disc, and around the macula, there is no specific changes though. And the Opta is showing that the network has increased and now crossed the median raphe and gone inferiorly. Still, there was no fluid, but considering patient was symptomatic and was having hemorrhage, we started the treatment even though the vision was 6/6. As you can see, and we did an FFA ICG to confirm the diagnosis. At this point of time, we had the Heidelberg FFA ICG, and that's how the SLO images are there, which shows a beautiful network in the left and the right eye has a scarred CNV. So we leave alone the right eye because the patient also doesn't want the treatment, and left eye we keep treating as much what is possible. So right now, this is after 3 loading doses. We can see the small hemorrhage which was there in the superior temporal area to the disc has resolved. The vision remains the same. The patient is happy. And this is after the treat and extend protocol, which I usually try to follow, is what we are seeing, that there is no hemorrhage, there is no fluid in the retina, below the retina, but yes, the PED still persists, and there is a small PED which has started to occur in the inferior temporal area to the fovea, which was not there before, like as you can see in all the slides. And this is after the 5th injection. As you can see the timeline over here, this is in September, and this is in October. And suddenly the patient has had a large PED with SRF SHREM. The vision had dropped to 660. Considering still after a lot of discussions with her, what to treat, what not to treat, still we persisted, and then we gave eccentrics. And this is just after 1 week of eccentrics, or 3 days, if I remember, that the patient had bled, and the bleeding was subretinal, sub-RP. Considering one-eyed patient, my thought process was to give probably TPA and gas, but after a lot of discussions with her, whether to do, not to do, what to do, somehow the TPA was sourced, and then we were able to do the surgery and then try to do a pneumatic displacement with a subretinal injection of TPA and air and anti-VEGF. And this is with the usual procedure. What I follow is to peel an ILM around the macula or the area which we are planning to inject in the subretinal space. And this is the area which I identified in the pre-op OCT, that where the PED was not there. So the inferior temporal area where I can see that is more retina and not a PED over there. So injected some amount of air. Yes, as we can see, there are transmitted movements, and yes, a little tense surgeon. So we tried to inject the TPA in the subretinal space, but I think there was some which was injected into the vitreous cavity also. We did a partial air fluid exchange, and this is immediate next day. The patient was not very happy because, as you can see, the image is not very good. There is a diffuse heme. But when we closely observe the photograph, if we try to compare the pre-surgery photograph and the post-surgery, as you can see, this is a partial fluid superiorly, and this is the subretinal air bubble which is there. With our surprise, what we can see is the disc macula was just seen, and then the hemorrhage was all migrated below. So the surgery has done the trick, but the vision was not improved. Patient was not very happy, and this is 1 week later where the patient came to us that there was presently still no vision, or there was further worsening of the vision. And this point of time, the patient was having some CF meter. We did a B scan, and there was a suspected inferior detachment. So I thought probably because we have done a TPA gas, and obviously that would have migrated inferiorly, so we had a close observation, but it persisted. And after a lot of discussion with the patient, considering one-eyed, I told, okay, better to intervene and let's understand what's happening inside. And this is what we can see inside, that a large macular hole has occurred, and there is the sub-retinal hemorrhage has gone away. So, and there is areas of RP rip which can be seen, and this is the primary area from where I had injected the TP in the subretinal area. So I did a re-ILM peeling and a little extended peel. Right now, the macular hole was very large. Considering one-eyed, I thought why to try something new. This was my first and the only
So the
retinal
time is
autograft which
over.
I had tried, where we can see that I have taken a graft from the detached retina inferiorly, and under PFCL, when I'm trying to shove the graft onto the retina, as you can see, it's either getting folded up or not allowing me to go onto the retina. So in this case, I removed the PFCL. I kept a very small bubble and then kept it over there. But over there, the issue was there is a large PED temporally, what we can see over here. That's why it was not, I was thinking whether it would allow it to sit over there or not. So that's why I thought of doing an underlay or to push the graft below the retina so that it doesn't go out because of the large PED, which was just temporal to the fovea. So I used a soft fluid and then I pushed the whole graft into the retina and then completed the air fluid exchange, removed the PFCL, did the laser to the area of the graft host, and then did a small laser around the area from where I had intervened using an TPA. So this is first day post-op where we can see the retinal graft is seen well aligned into the retina. And there is a very tall PED just temporal to it. So that was my worry whether to do just over it or below it. But I took an option to do an underlay. And this is 1 week later where we can see the graft is still very well seen. This is a follow-up of how previously the retina was looking. And this is after one day we can see that the integration of the graft, I am not sure at 1 day or 1 week how it was, but the Octa was showing that there were some networks or some superficial capillary network which was maintained. And this is after 7 days where I couldn't recognize because those cautery marks had gone away, but the autofluorescence is showing that that area is still having those retinal graft, and that's why it is not hypo, but a little hyper. And this is a comparison. What we can see is 1 day to 7 days where the cautery areas have healed well, and that's why that is not seen. And this is a comparison of 1 day to 1 month. As you can see right now, there is some kind of a foveal contour, but as you can see, there is some kind of a retinal layers also which are seen, which usually should not be seen. So that's the usual retinal outcome probably of this autograft. This is my first attempt, so I am not sure about
So
it.
the time is very much up.
Yeah, so the point of discussion is pneumatic displacement versus TPA versus saline, or peel or not to peel at the fovea, nuances of subretinal injection and nuances of retinal autograft. Retinal autograft either overlay or underlay. Thank you.
Very nice.
Thank you. Thank you, Divyansh. I think you're very dare to show the complication which you have faced. I think we all appreciate it. It keeps happening. Just a few points before I give it to the expert panel. Divyansh, I have burnt my hands in doing ILM peeling in cases where we give the subretinal gas. Even I have faced a similar situation where it was a very small thin film of subretinal blood. So since I had gone in, he also had an RD. So I thought, why not give a subretinal injection since I've gone inside? And I peeled off the ILM and gave it. He turned out with a macular hole. But when you manage the cases of macular hole, definitely it's important. It doesn't come out with the teasing itself. You need something. So when you had the PFCL and you were extending, the first thing I would have tried in my case is to just do a ILM transplant, just to try to trace it and bring it over the macular hole. That could have been done. If that also fails, then I would have gone in for the retinal autograft. So initially I used to do like how you showed, is remove the PFCL, put the graft, and then put the PFCL over it. But the problem is you have to tuck that graft inside in the edges of the macular hole. But sometimes with the blunt instruments, there are chances that it will hit the RP and the whitening might cause inside the macular hole, then the whole purpose is defeated. So rather what I would suggest is put a large bubble of PFO, extend it beyond the arcade, and then just slide it. But we have to remember, in case if it slips, it floats over the PFCL. Because it is lighter than PFCL, it keeps floating, that graft of the retina. Then again, you have to remove that PFCL. Some people have even used viscoat to just put it in the macular hole temporarily for it to stay, and then use a PFO and then do a careful fluid exchange. In those cases where you see the slippery graft, sometimes they won't, unless you tuck it. But the other thing is where Dr. Rupak Biswas has also devised a tree fine. But the problem with that is it has a minimal, I think it's a 20 or 21 gauge tree fine. So only that size of the hole can be cut with that tree fine. But if it's a larger size, then you have to again extend it. So that's the one. And overlay and inlay, I think now safer side is better to go with overlay, because again, you're tamponading it with the gas or the oil. And we have seen in my 16 cases, I have even seen the retinal outer layers coming back. So I really do not have differentiating between the overlay and the inner lay, but definitely even the overlay also does good. And if it's a snug fit, like how we do a corneal tree fine and try to do only that, then I think that would be the best. If not, then even the overlay also works well in these cases. Just few of my observations. Thank you.
Sure. So thanks to some answers from my side. One, she was one-eyed. I had to give whatever the best is. So that's why I opted for this. As I told, this was my first. Second, the size of the graft, because there are publications where the graft also constricts after some period of time. So that was a little doubt. That's why I did a little larger graft. Underlay, overlay, as I told you, I am not sure. I just thought this would be better, than the slippage would be much lesser. And because it was like one side, there was a PED. So I thought the slippage would be more. That's the only reason. Yeah, sure.
No, I think overlay works best, Divyansh. You have done a wonderful job. I think that's all. I also do it nowadays. Any comments from the expert panel, please? Or we can go ahead with the next case.
We have many more speakers. So we go on to very nice, Dr. Divyansh. We go on to our next speaker, Dr. Madhu Kumar, who's a senior consultant Vitro Retina Services from Shankara Eye Hospital, Guntur. And he is going to tell us about true intraocular foreign bodies story. Yes, on to you.
Thank you, ma'am. Thank you, Dr. Srinivas and ma'am, for this opportunity. Can you see my slides?
Not yet.
Not yet, sir.
Now?
No.
Okay.
Sir, you need to press the green button on the
now.
Yeah, now can you see it?
We are able to see it, sir.
Okay. Just a second. Okay, so basically, I'll be presenting two cases of foreign body. Just a second, there's something wrong. Okay. Yeah, so terming the nasty intruders, a tale of two intraocular foreign bodies. So this is first case, a 30-year-old male. His complaint was a pain and diminution of vision both the eyes. So there's a history of the glass container blast injury at a factory. His best corrected visual acuity in the right eye was PL and PR accurate. And this is how it looked. Multiple corneal tears with multiple glass foreign bodies in both the eyes with intraocular foreign bodies. So the patient underwent emergency primary corneal tear repair in both the eyes and lid repair. And then patient was asked to do with the imaging CT scan. As usual, in our part of the state, like the patient was lost for follow-up and he turns up 1 month after to us. And this is what we see. This is the left eye where there is a single large glass intraocular foreign body with vitreous hemorrhage. And the CT scan showed the right eye, there are 3 glass foreign bodies, and the left eye, there's 1 glass foreign body. And there were multiple foreign bodies embedded in the maxillary, intraorbital, and frontal region. So this was the diagnosis. And obviously, we had to look at the problems we face when we are handling these cases. So I'll show the video. This is how I had to go about it. So the primary challenge in these cases will be the visualization, because already the corneal tear repair scarring is there. The other problem will be the instrumentation, because these glass foreign bodies are not easy to handle. They are very slippery and it's very difficult to grip. So what one of these foreign bodies, which was in the anterior segment, I could place a visco in the anterior segment and then remove it, place it on the iris. And the other foreign body, I could dissect it. All the vitreous and the blood clot around it was dissected, and using the cutter in suction mode, I could retrieve it and place it on the iris. So then using the visco expression of this foreign body was done, because otherwise if you try to grasp with any forceps, it can just ricochet and it will act like a bullet, it can go back. The challenge was retrieving the third foreign body, which was large. I tried with the cutter, but I was not successful. And then I used the extrude needle, the flute needle, which has a round end facing bore. And in the suction mode, I could catch hold of it and again carefully, it was placed on the remnant iris, and then it was using the visco expression, it was retrieved. So carefully note this, when I try to hold it with the forceps, it goes like a bullet when we close the forceps. So this is one thing which we have to keep in mind while handling the glass foreign bodies, that the instrumentation, we have to be careful, and with what we need to do is use a flute needle in aspiration mode and then retrieve it. So this was coming to the second case. Yeah. So this is how it looked. Patient improved to 6/60 with the corneal scarring. The other eye I chose to observe because the glass is an inert foreign body. I've been following this patient since last 2.5 years. He maintained 6/9 in the left eye, and this is how the right eye looks. So coming to the second case, this patient had an upper lid tear with a injury in the workplace of 2 hours duration. His best corrected visual acuity was 624 in the left eye. He had an 8x1 millimeter upper lid laceration and scleral tear measuring 8x1. The entry wound was at the 12 o'clock, extending from equator to the near periphery inside the eye, and there was a large foreign body sitting at the 6 o'clock with vitreous hemorrhage. Again, how do we proceed with this case? So we chose to do a 2-step surgery because the defect was pretty large and the foreign body has entered through the insertion of the superior rectus. So I took help of my squint surgeon. They did a disinsertion and sutured the scleral tear and reinserted the muscle. I waited for 5 days time, and then we got a CT scan done, and this is the dimension of the foreign body, 8x4.10 to 2.7. And this patient was driver by occupation. So the challenge for me was to save the lens. I didn't want him to. So I chose to do for vitrectomy and lens sparing foreign body retrieval. The initial steps are as usual: a good thorough vitrectomy, clear the vitreous adhesions, induce the PVD, and then carefully with under depression, the foreign body which was embedded onto the vitreous and the retina was carefully dissected, and it was made to fall onto the retina. And I already placed a PFCL bubble on the macula, and then the blood clot was removed. So this was where the superior tear, you can see that, which is now kind of well cell sealed. And the foreign body area was well lasered because this can have a micro breaks and later can lead to detachment. And also the tear, which was kind of cell sealed. Now I did a laser around that. But now the challenge was how to retrieve this foreign body. Usually these kind of foreign bodies, we tend to sacrifice the lens and bring it through the limbus. But then this patient was, as I mentioned, was a driver, and everything else macula looks fine. So I thought of doing a sclerotomy and removing it. And this was the challenge. I used a basket forceps and I'm trying to retrieve it, but it is falling off. So the key challenge was to engage the foreign body in the axis where the least diameter comes out first. So I did using a handshake technique where left hand, the intraocular magnet was used, and using the right hand, the foreign body was engaged in such a way that the least dimension of the foreign body was grasped using the basket forceps, and then it was retrieved out. So this is the post-op results of this patient. Sorry. Yeah, so at 1 month follow-up, the best corrected visual acuity in the right eye was 6.6, and left eye patient improved to 6.9. So this is just to show that foreign bodies are definitely challenging for VR surgeons, because for all of the surgeries, we have a standardized instrumentation like cutter, light pipe, scissors, ILM scrapers, picks, and these things. But intraocular foreign bodies are something where we have to innovate in every case. Thank you.
Thank you very much. Very interesting. Very nice case.
I think Pramod sir and Raju sir.
Yes.
Yeah, actually, I mean, good videos. But the dictum here, if patient come to VR surgeon, to start with, I would prefer to remove the foreign body along with primary repair, unless there is other compelling reason you can't do. But somebody anterior-segment surgeon who is not comfortable with, or not experienced with, not trained, or doesn't have setup, he doesn't have any choice but to do primary wound repair and send to VR colleague. Because just for the sake of VR colleague, primary wound repair should not be delayed. That's a primary, most important thing. But as we have burned fingers, even if iron body does not mean that what old days we used to teach that it's a missile-like thing, self-hitting, and then it becomes sterile. Not anymore. We have cases where delayed removal and it landed up into bad endophthalmitis and we lost eyes. So given option, of course, media and other factors, obviously, have to take into account. And then there is compelling reason. I would prefer to remove foreign body at the same time. That's the first thing. Okay.
Yes, sir. In this case, I chose to do two-step because the tear was pretty large, sir, from equator till the periphery. So
yeah, I agree.
I was
not. Yeah, that's why some compelling reasons are there where practical difficulties, then you don't have choice. And probably you could do a better job. You wanted to save the lens. And I think you could achieve that one. So definitely it help eventually to achieve your goal. Yes, with the taking a risk of may land up in endophthalmitis.
Yes, sir.
With that calculated chance you have taken, fortunately it worked out. Definitely. So
yes.
I mean, really, done a very good job you have done that way.
Thank you.
So basket forceps when you use, probably I would have used a basket forceps rather than trying regular forceps when you're using glass foreign body. Because I agree what you have shown very well, you just cannot grasp slippery surfaces, and they try to grasp, either it keeps on slipping or it breaks into pieces. Again, small bits and pieces hitting here, then sometimes removal become extremely difficult. But when you use a basket forceps, the mechanism is such you can enter through the sclerotomy, but once you open the basket to grasp foreign body, no way you can come out through your same sclerotomy. And that situation, probably the best way, you have to bring into anterior chamber and get thing out through the limbus. Okay. So third important thing is, because when you enlarge the sclerotomy, there's a high risk of sclerotomy related complication, and particularly dialysis, and also the big foreign body coming through. It's very important you shave vitreous in that area extremely well. Even though patient is having it's a phakic, try to depress and clean the vitreous nicely, because otherwise vitreous, again, if irregular foreign body, again vitreous get entangled, and when foreign body comes out, eventually will land up in dialysis. That's another problem. And once you remove the foreign body, large sclerotomy, so additional work if you are done in the vitreous cavity with a leakage sclerotomy, subsequent management become difficult. So you have to resuture it, make a smaller one and continue, or maybe somewhere other location you can make another scleral cut just to take out the foreign body. Okay, now here 12 o'clock area was not available for you because it's already suture. Otherwise that can be a good location. So you pick up foreign body through a sclerotomy and get it out through extended incision at somewhere 12 o'clock or something, occasionally 6 o'clock. Suture that incision fully, and then your other three sclerotomies are undisturbed. You continue your whatever intraocular work you want to do.
Thank you, sir, for those.
But very well managed.
Yeah, very well managed, Dr. Madhu, sir. Yeah, Raju, sir.
Well managed, Madhu, as usual, very nicely done. You are very lucky with such a large foreign body, you didn't have a lens touch. So probably there is a chance that you could have had a lens touch only. I would have probably planned for a cataract surgery itself. My threshold for removing that lens would have been very less with such a large foreign body in place. And this patient is anyhow going to develop a cataract in a few years' time. So it is better to do it now in a planned way and avoid these sclerotomy related complications, as Dr. Pramod Bendisa was telling. But anyhow, very well managed. You are lucky. Good, great surgeon. Thank you.
Dr. Raju, I will keep cataract surgery ready, assuming I may touch the lens. I'll give a chance. If it works, fine. Doesn't work, anyway, I plan for cataract surgery.
Exactly, sir. That's what I did. I had prepared for a cataract surgery. So luckily, I got away with it.
Yeah. Thank you very much. We
Thank
go on
you.
to
I think next we have Dr. Ganesh Pillai. I request George sir, Rajiv sir, and Mahesh sir to please moderate this.
Senior consultant from ASGI Hospital, Bhopal, and he's going to tell us about autoimmune retinopathy.
Thank you, ma'am. I'm Srinivas sir for the opportunity, and thank you ARC for organizing such a beautiful event on different cases and videos. I'm Dr. Ganesh Pillai, and I'll be talking about a case which encountered in 2018. A 25-year-old woman came with sudden onset, painless diminution of vision in both the eyes. And apparently she was asymptomatic 5 days back, and she had a profound diminution of vision, which gradually increased over next 5 days. Rashes were there in both her legs below the knees since 2 weeks, and occasional history of joint pains was noted. There was no history of any flashes, floaters, redness, discharge, or any significant visual symptoms before. There was no family history as such, which was contributory in nature. Systemic ocular examination, her best corrected visual acuity was 5/60 in the right eye and 6/60 in the left eye. Anterior segment evaluation showed no cells, no active signs of uveitis, no keratoconjunctivitis, conjunctivitis, episcleritis, keratitis, or iritis. The posterior segment evaluation showed the disc was little hot, otherwise 0.2 cupping, and no edema as such. The margins were clear, no NVD. Multiple cotton wool spots were seen along vessels reaching up to the fovea, and retinal thickening was noted, suggestive of macular edema. The vessels, there were multiple cotton wool spots with a free zone around the vessels, no perivascular infiltrates or cuffing, no evidence of any sclerosed vessels on presentation. Similar presentation was noted in the left eye as well. General cystic examination, the only positive history examination notings were a purpuric rash, which was present over her shins and dorsum of feet. Oral examination had apathous ulcers over the buccal mucosa. Otherwise, systemically okay. On OCT examination, cystoid macular edema and retinal ischemia changes were noted in both the eyes. So from day 1 to day 10, there was increasing ischemia. Actually, the problem was on day 1 presentation, we could not do a FFA. And we had to plan for a few investigations. And after that, we planned for an FFA. Based on the clinical presentation, cotton wool spots, a person-like retinopathy was a differential systemic vasculitis, which included SLE, PAN, vaginous granulomatosis, Chuck-Strock syndrome, and cryoglobulinemia were the differentials. Based on the capillary non-perfusion areas, SLE, PAN, vaginous, Chuck-Strauss, Crohn's, Susac, cat scratch, Mediterranean spotted fever, and ocular toxoplasmosis. And based on the rashes, differential was Lyme's and rickettsia. So we planned for a few investigations, and the investigations showed us positive. Patient was anemic, leukopenia was noted, ANA positive, strongly, anti-dsDNA also positive, ANCA was negative, HLA, B27, Lyme's titers, rheumatoid factors, MON2, chest X-ray, ESR, serum pancreatic amylase, and creatinine were all within normal limits and and were negative. Post doing a KFT, we planned for an FFA, and on doing an FFA, we saw a patchy choroidal filling, multiple non-perfusing arterioles with adjoining capillary non-perfusion areas, enlarged FAZ, indicative of macular ischemia, staining of arterioles, and few microaneurysm could be seen. So we planned for an intravitreal IV methylprednisolone, 1 gram was given for 5 days, followed by oral Visalon. Right eye, followed by left eye, anti-VEGF was given. A rheumatology referral was done, where she was started on rituximab, cyclophosphamide, and mycophenolate mofetil. Sectoral laser was planned, but the patient lost to follow-up. She had convulsions later on, and she had gone to Mumbai for her rheumatology treatment. When she came back after 5 months, her FFA revealed again patchy choroidal filling with multiple sclerosed vessels and a capillary non-perfusion areas which are very large. Enlarged FAZ, neovascularization at disc, and multiple microaneurysms were noted. So we planned a right eye followed by left eye anti-VEGF, and the rheumatologist continued with rituximab, cyclophosphamide, and mycophenolate mofetil. Sectoral lasers were done, and patient improved from to 636, and to my surprise, in the right eye improved to 612 after 3 months of treatment. The discussion part, basically, autoimmune retinopathy has different presentation. It can SLE also fits that criteria of autoimmune retinopathy. Essentially, the diagnostic criteria for any autoimmune retinopathy should have no apparent visual function abnormalities or ERG abnormality should be there. Presence of anti-retinal antibodies and presence of fungal lesions and retinal degenerations may explain the visual functional loss should be there. Without any intraocular inflammation or cells. The diagnostic evaluation basically includes the ERG, fundus autofluorescence, fluorescein angiography, and OCT. What I want to bring to the notice is that alpha enolase is a most common anti-retinal antibody, which is positive in systemic autoimmune disease, which includes SLE. And this has been histopathologically shown to be one of the presentations, and it is often unnoticed because of the lack of fundus examination in SLE patients. So in SLE, diagnostic criteria 4 out of the 11 should be present, and one of the immunological anti-DNA or anti-ISM antibodies should be present for the diagnosis of SLE. So my take-home message here is that it is one of the common presentations of SLE to present as SLE retinopathy in approximately 33% of the patients. Most common findings which are there, like cotton wool spots, phlebitis, arthritis. Other than these, sometimes it can not present like this, and there can be pigmentation around the vessels, which may look like a RP, like a picture may be there. Alpha enolase antibodies should be try to be seen in these patients, because it is prognostic to see if you diagnosed SLE retinopathy, there are chances that the patient may be having a acute SLE crisis, where the patient may have neurological as well as renal functional abnormalities. And screening of all the patients of SLE is very, very essential, especially young individuals, and starting them on biologics like rituximab are life-saving and vision-saving outcomes can be there. Thank you so much.
Thank you. Very interesting.
Thank you. Thank you, Dr. Ganesh. I think that was really an eye-opener on the SLE. Thank you very much for that wonderful case presentation. I think George sir is waiting. Yeah. Go ahead, George sir.
Nothing. I hear when you saw that presentation, bilateral presentation, I just want to draw your attention to your fundus feature of bilateral, not only cotton wool spots. You have seen that the bilateral, it is much larger than, some of them are much larger than cotton wool spots, and it was between the interarteriolar watershed ischemia. So this fundus, now there's a spectrum, and you saw that it was progressing from day 1 to day 1 week, and then 10 days. Progressively, it went into a CRAO kind of fundus picture, actually, from what progressively. So now, in earlier days, we used to call this purchase like retinopathy and other, when we didn't have high definition OCT and to see the level of lesions. But now with the MacLeod's classification, with this hypoperfusion, especially bilateral hypoperfusion maculopathy has a type 1, 2, and 3. Your presentation was typically into the type 2 hypoperfusion maculopathy, which progressed to type 3, almost a complete, from partial to complete CRAO kind of picture. The fundus picture, those became more confluent and became a pale retinal edema. So when, and as you have started the methylprednisolone, this kind of a picture, I think unilateral or bilateral. Unilateral, we have to suspect conditions like carotid dissection or giant cell arteritis. When you see bilateral, immediate referral and probably starting that IV methylprednisolone, I believe in the, as a priority, probably will prevent this vasculitic occlusion. This is mostly like a occlusive vasculitis progressed over 10 or 14 days. So I only think that that methylpred would have, if you had given on the first 2-3 days, it would have prevented the progression to a occlusive vasculitis kind of thing. So this is what I feel. Rest everything you have managed very well, and a very good case for discussion. Yeah.
Sir, but he was already on cyclophosphamide. He was already
No,
on
no,
many
no.
other
At presentation, he was
immunomodulators.
not
But
on
when
anything.
do you think would be to start?
No, he was a naive case, isn't it? Am I right?
It was a knife case.
Yeah,
So
he was
IVMP
not.
was given in the first visit or in the later visit?
No, no, no,
First
no.
visit.
First visit. Achha, okay.
After, I think the
The patient was given it later because of the fact that the diagnosis was unclear in the initial presentation, and directly jumping onto IVMP in the first presentation with rash in the shin was a little bit dicey, because any kind of
what I meant
infective
to say is,
etiology.
get a referral immediate, and the starting of IV methylpred here was done 14 days, I mean a couple of weeks later. So in this kind of a clinical picture, I mean, you have well managed it, but I would have more aggressive in diagnosing and referring and getting the C-reactive protein and everything, and see the inflammation, and start the treatment a little bit earlier would have prevented, I feel, in this case. Otherwise, well managed case.
Yeah.
Rajiv sir and Mahesh sir.
I think excellent, very good, well managed case. And as Dr. George rightly said, it's a very dicey situation. You want to rule out infective causes because you don't want to immediately start IV methylprednisolone. And the problem of getting all these antibodies, it takes a little time. But as Dr. George rightly said, if you have those inflammatory markers of CRP, ESR, those raised, you should keep alarm, keep a little close watch. And if you see worsening of the ischemic component, better to start IV methylprednisolone, because if you more early you start, you can prevent the progression of disease. As far as alpha enolase is concerned, and other, even there's another set of conditions where it is autoimmune, like it's not only SLE is one of them, but some of these they may not have ischemia, but they may have some pigmentary change. No, so if you see the pigmentary change in a gentleman more than 40-50 years, CAR-MAR and all these type of antibodies, you start thinking about who doesn't have like picture like a RP, which has come only after old age. He never had these symptoms. Start thinking and get alpha enolase. We routinely don't do. The other set of antibodies are more commonly done, and they progress very fast. It's a hurricane. Like couple of days you see, and in your case you didn't had the hemorrhages. So many times it's not only the cotton wool spot, you have massive hemorrhages, you have both combined artery vein occlusion. And as you rightly said, majority of them, their survival rate is less. They have CNS ischemia too. So you need to send to the rheumatologist early and have a close watch on these.
Thank you. Thank you for those.
Yeah, thank you very much. We go on to our last.
Any last comments before we go on to Dr. Darayas?
I think a lot of learning points. I have nothing to add. Excellent case, Dr. Ganesh.
Excellent. Yeah.
Thank you. Thank you, Dr. Ganesh. And then we have the bomb for the last.
Yeah. Bomb, Dr. Darayas, Medical Director of Shroff Eye Care Center, and looks tired, Darayas.
No.
And not fair to have made you the last speaker.
He's going to put a bomb now, madam.
Yeah.
We are going to close the webinar. That's why we have kept the bomb for the last.
Thank you so much. Thank you to ma'am and to Srinivas for this opportunity. So during the pandemic, we saw some of these white bombs in the eye, these cases of fungal endogenous endophthalmitis after intensive corticosteroids and COVID. And it was not only us, these were reported from LV Prasad, where they reported more than 44 eyes. And in fact, there were so many reports that the IGO had a commentary also entitled The Daunting Enigma of Post-COVID-19 Endogenous Endophthalmitis. So I just want to bring two interesting surgical cases because Srinivas said he would like to see the surgical ones. So, and also some learning from these. So it's a video. I'll just run the video. Just let me know if the sound comes. Patient lost vision 2 weeks after discharge from the ICU. and came to us with a total retinal detachment and inferior retinal abscess. During the vitrectomy, we removed fluffy white fungal clumps, debulked the inferior retinal abscess, and peeled the PVR membranes. Superonasally, the membranes were very tight. We dissected these bimanually with our forceps and the light pipe, and then trimmed them with a cutter. The retina settled and silicone oil was injected. The material removed from the retinal abscess grew Candida albicans. At the end of the surgery, we were surprised to find episcleral creamy white material, which we dissected and sent for histopathology. These turned out to be refractile crystals of a periocular triamcinolone acetonide steroid deposit. This patient was initially diagnosed as non-infectious uveitis and loaded with steroids of every form. We administered intensive antifungal therapy. The endophthalmitis cleared and the retina was stable post-operatively. Our next case was diagnosed elsewhere as diabetic macular edema and was referred to us for anti-VEGF injections. We noted CME on the OCT, but surprisingly found a yellowish creamy lesion superonasally in the fundus. We treated her with oral and topical voriconazole. The CME resolved and vision improved. However, 4 months later, there was fibrosis in this area causing a tractional retinal detachment. We placed a belt buckle and tried to release the traction bimanually. Then we delineated the fungal granuloma with a cutter and cauterized its surface. Post-operatively, the retina is stable with good vision. So these are the two videos. So basically, wanted to, in the first case, what was interesting is after we completed and we saw this white material, we were wondering whether there was some fungus growing or something, which was very rare. And then luckily we sent it for histopathology and found these crystals. So I think the cautious use of steroids in all cases, because we have varying diagnosis, we should always rule out an infectious etiology, especially fungus, before using steroid. And the second case, I think what was very interesting is this was a lady who was the wife of a senior physician. So the doctor who sent her, actually the lady was diabetic. So they sent her to me to give anti-VEGF because it was such a VIP. The doctor was go to the house of the patient and look at the retina in the person's house. So they were not bothering, they were not able to depress properly. So I think even if we have VIP patients, we have to be very careful to examine carefully because this whole thing was totally a different picture actually. It was because she was in the ICU for COVID that she developed this. And it responded well to voriconazole. So that was all.
Very interesting. There is newer viewpoints.
Thank you, Dr. Darius, for those beautiful two cases which you showed and brought up the little bit topics of debate. I request the expert panel to please give your suggestions. But Dr. Darius, in most of these cases, if you do a KOH negative, immediately you send to your lab in your hospital. And once you see that it is KOH negative, then what I do is usually I try to give dexamethasone also along in these cases when you confirm that it is bacterial. But I know it's again a debatable topic and it's a controversy whether to use dexamethasone in these cases where or just by KOH itself might not be sufficient sometimes and it might cause a devastating effect is what many other authors would like to say about it. But I would like to know from the expert panel about what he's telling about the cautious use of the steroids. And if it is a pure bacterial, say after doing a vitrectomy and doing a PVD induction, removing most of the infiltrates and everything, then would you still use a dexamethasone or definitely it's not a drug of choice to be used? Rajiv sir?
Yeah. Not at the first starting because the way of presentation, if you see COVID, steroid, it may be IV. So they are all linked to, you have a suspicion of fungus.
Yes.
And just based on a negative KOH, I would definitely not give a steroid during surgery. However, during follow-up, once you are sure that it is not there, you can still, because you definitely want to control inflammation too. And that time, along with your antibacterial, you can give a steroid. But I think during surgery, I would be a bit hesitant looking like those fungal balls, those balls which were there, the type of thing, your suspicion is more towards fungus. So not in the starting, definitely. And definitely not intravitreal steroid. You would prefer probably to start on some topical steroid, and that too on a very minimum if inflammation is increasing.
Sir, even in cases when you know that it's a bacterial infection, there is retinitis, there is hemorrhages, and there is an inflammation over the near to the macula and over the macula. In those cases also, you won't advise using steroids in the first
Bacterial,
instance.
if bacterial is 100% sure, you are sure about bacterial, definitely give steroid along with antibiotic.
And that too intravitreal, or you prefer?
Intravitreal, if you are sure that it is bacterial. But in this case, the clinical picture, the circumstances, it is more going towards a fungal. So definitely in these cases where there is a little doubt, better to avoid steroids.
Thank you, sir. Raju, sir. Dr. Raju, sir.
Yeah. Like already Dr. Mahesh has told, I also have burned my hands missing those cases. And one case I had injected a IVTA, and that turned out to be a fungal end off later, and we lost the type. So a word of caution, especially when you're treating UATs cases. And after that, I've stopped giving any intravitreal steroids for these cases. I usually try to prefer to treat with the periocular steroids, and most of them do well. And if it is, and at least we get saved ourselves from getting into these tricky situations.
Yes, Mahesh, sir.
Agree. Well, better to do some treatment which can be reversed if you find it is harmful to the patient. So if you put everything inside, is little. So avoid intravitreal unless you are very sure.
Yeah, I think Srinivas, there's no doubt bacterial infection, if you're sure, like a post situation, those are totally different situations. These are ICU patients
exactly.
who
In this case, no chance.
So that was a different situation. But I think
that's why I want to know, in different situations, what are the experts panel views on using the dosage of steroid? Your cases were almost clear cut, more looking like the fungal cases, and definitely everybody will burn their hand. But also, there is do you feel any difference between the dexamethasone and the IVTA when you are confirmed that you are giving it? Because I've seen many people or myself giving dexamethasone, but Raju sir was telling about IVTA giving. Do you think, because is the potency, I feel IVTA is more potent than the dexamethasone? And do you have any preferences or choice?
I do agree with what Dr. Rajiv and Dr. Mahesh said completely. Great cases there is very good. The second case is really challenging. I don't know how you picked up that lesion for a small CME macular edema. Great cases, well managed. I agree with whatever is being discussed here, but IVTA is strict no for me, because DEXA would be a short acting, and we want only a short acting, because we would be repeating the intravitreals. At that time, we can repeat the DEXA also if you want to continue. IVTA once put, you cannot take back. So as Dr. Mahesh very well said, you don't want to put anything which you cannot take it back. So
I think I got it wrong. And I meant that not to use steroids intravitreally. And for bacterial infection, I give DEXA only. The IVTA I was telling was with regard to a missed case of uveitis, which I where IVTA.
Correct. Srinivas is trying to put a white bomb in the eye. He's telling us something with a white bomb.
You already put so many bombs, no bombs.
Even posterior subtenon, if you want to reverse it, taking it out is not easy.
Very difficult, sir.
Very difficult.
Yeah. Fantastic. Thank you, Dr. Darayas, for showing two beautiful, interesting cases. And thank you all the expert panel.
Yeah. Thank you very much. Thank you very much, dear expert panel, and wonderful talks. And I need a special prize for sitting with you all 3 hours. Not even a second I switched off. But truly interesting, wonderful. Thanks so much. And thanks a lot, Srinivas, for moderating it so seamlessly well and keeping all the expert panel so involved and staying right till the end. And of course, need to thank Mr. Sunil for being there in the background and helping us along. Thanks a lot. Of course, thanks to AIOS, Mr. Kripal and his team. Thanks to Sai and Manjula from Numerotech. and definitely Entod for sponsoring all our webinars. And finally, most importantly, thank you very much, delegates, for making us keep coming back to you week after week with the same amount of energy or increasing energy to keep it interesting for all of you. Thank you very much. Thanks a lot.
Yeah, Madam,
Thank you.
Chitra Madam,
Thank you,
I
ma'am.
think
Thank you, sir.
for the expert panel, last time we had kept a retinal Brahmastra, I
Yeah.
think which had more than 1,000 views. And that's why we have kept a fancy name as Retinal Avatar, because
Yeah.
it is very newly launched. And I'm sure that we are going to cross 1,000 views for this webinar as well. Thank you very much, all the
You
presenters
have
and the
not
expert
watched
panel.
Retina guys who have not watched it. I've lost a moment. So I'm sure it was a very excellent speakers. Great job.
Thank
Let's
you.
get back.